I'll be talking about intravascular imaging in coronary artery disease, and whether
and
this
whether
is
this
an
is an
important
important
thing
thing
for all
for all
patients or
patients or
not to
not
get
to
a
get a
coronary
coronary
intervention.
intervention.
For
For
disclosures, I have
disclosures, I have
nothing to
nothing to
disclose.
disclose.
In terms
In
of
terms of
what we'll
what
be
we'll be
looking at,
looking at, we'll
look at the
look at
role
the
of
role of
intravascular
intravascular
imaging,
imaging,
different
different
invasive
invasive
imaging
imaging
modalities for
modalities for
coronary artery
coronary artery
disease,
disease,
see the
see the
differences
differences
between
between
intravascular
intravascular
ultrasound
ultrasound
versus
versus
optical
optical
coherence
coherence
tomography, which
tomography,
is
which is
OCT,
OCT,
and
and
then just
then
go over
just
a
go
few
over a few
cases of
cases of
IVUS and
IVUS and
OCT.
OCT.
In terms
In
of
terms
role
of
of
role of
intravascular
intravascular
imaging,
imaging,
it is
it is
evolving
evolving
so
so
much over
much
the
over the
last few
last few
years
years
that
that
we can
we
see
can
this
see
really
this really
well
well
depicts
depicts
how we
how
can
we
use
can use
intravascular
intravascular
imaging in the
imaging in the
pre-intervention
pre-intervention
phase,
phase,
as well
as
as
well as
something that
something that
can be
can be
used for
used for
guidance of
guidance of
PCI for
PCI for
optimal
optimal
results.
results.
In terms
In
of
terms of
trials of
trials of
intravascular
intravascular
imaging, there
imaging,
are
there are
multiple
multiple
trials
trials
that
that
have
have
shown the
shown the
role
role
and
and
benefit of
benefit of
intravascular
intravascular
imaging.
imaging.
One of the
One of the
trials is
trials
the
is the
Ultimate
Ultimate
trial,
trial,
which was
which was
published
published
in
in
JACC
JACC
Intervention in
Intervention in
2021,
2021,
one
one
of
of
the
the
more
more
recent
recent
trials.
trials,
A
a
randomized
randomized
controlled
controlled
trial
trial
looking at
looking at
patients
patients
who
who
underwent
underwent
PCI with
PCI with
IVUS
IVUS
guidance
guidance
versus
versus
just
just
simple
simple
angiography.
angiography.
And we can
And we can
clearly see
clearly see
that
that
the
the
target
target
vessel
vessel
failure in
failure in
patients who
patients who
underwent
underwent
IVUS
IVUS
guided
guided
PCIs was
PCIs was
significantly
significantly
lower
lower
over a
over a
period of
period of
3 years
3 years
compared
compared
to
to
those who
those who
just
just had this
had the
had the
PCI
PCI
done
done
based on
based on
angiography.
angiography.
Other
Other
trials which
trials
have
which have
looked
looked
at
at
OCT,
OCT,
IVUS, and
IVUS,
then
and then
OCT
OCT
versus
versus
angio,
angio,
all of
all
them
of them
have
have
shown that
shown
there
that there
is
is
advantage of
advantage of
using
using
imaging
imaging
modalities
modalities
to
to
improve the
improve the
outcomes
outcomes
in
in
patients
patients
undergoing
undergoing
PCI. I'm
PCI.
not
I'm
going to
not
go
going to go
into
into
details for
details
all of
for all
these
of these
trials,
trials,
but
but
just
just
a
a
brief
brief
overview of
overview
these
of these
trials.
trials.
In terms
In
of what
terms
is
of
the
what is the
difference
difference
between
between
IVUS and
IVUS and
OCT,
OCT,
so there are
so there are
multiple
multiple
different
different
IVUS
IVUS
catheters which
catheters
are
which are
available,
available,
and
and
there's a
there's a
single
single
OCT
OCT
catheter.
catheter.
So
So
IVUS
IVUS
works
works
on
on
the
the
principle of
principle of
ultrasound,
ultrasound,
whereas
whereas
OCT
OCT
works on the
works on the
principle of
principle of
infrared,
infrared,
near
near
infrared
infrared
light.
light.
One of
One
the
of the
biggest
biggest
differences
differences
which
which
I
I
would want to
would want to
point
point
out is
out
that
is
for
that for
OCT,
OCT,
you need
you need
to
to
clear
clear
out the
out the
blood,
blood, which is
why we
why we
use
use
contrast.
contrast.
So
So
in
in
patients who
patients who
have
have
worsening renal
worsening renal
function or
function or
CKD
CKD
not yet
not
on
yet on
dialysis,
dialysis,
advanced
advanced
kidney
kidney
disease,
disease,
you want to
you want
kind
to
of stay
kind of
away
stay
from
away from
OCT
OCT
to
to
prevent
prevent
giving
giving
additional
additional
contrast, while
contrast, while
IVUS does
IVUS
not
does
need
not need
contrast.
contrast.
Again, we
Again,
can
we can
see
see
this
this
article
article
kind of
kind of
just
just
summarizes
summarizes
which kind
which
of
kind of
lesions
lesions
can be
can be
seen better
seen
with
better with
OCT
OCT
versus
versus
IVUS. And
IVUS. And
the two
the
main
two main
places where I
places where
think
I think
about
about
OCT
OCT
comes
comes
first is
first is
to
to
understand the
understand the
mechanism of
mechanism of
stent
stent
failure
failure
and to
and to
see what
see
the
what the
culprit
culprit
lesion or the
lesion or the
mechanism of
mechanism of
ECS is,
ECS is,
whether it's
whether it's
plaque
plaque
rupture,
rupture,
plaque
plaque
erosion,
erosion,
red or
red
white
or white
thrombus.
thrombus.
Other than
Other
that,
than that,
IVUS can
IVUS
give us
can give
pretty
us
much
pretty
the
much the
same
same
data.
data.
So just
So
going
just
over a
going
few
over a few
cases
cases
now.
now,
We have a
we have a
68-year-old
68-year-old
female,
female,
past
past
medical history
medical
of
history of
hypertension,
hypertension,
hyperlipidemia,
hyperlipidemia,
and stage renal
end-stage renal
disease on
disease on
dialysis.
dialysis.
Basically, is
Basically, is
admitted to
admitted to
the
the
hospital in the
hospital in the
setting of an
setting of an
NSTEMI and
NSTEMI and
acute
acute
respiratory
respiratory
failure in the
failure in the
setting of
setting of
COVID-19.
COVID-19.
Undergoes a
Undergoes a
diagnostic heart
diagnostic heart
catheterization, which
catheterization, which
clearly
clearly
shows
shows
calcific
calcific
disease in the
disease in the
left
left
main,
main,
LAD,
LAD,
and
and
circumflex as
circumflex as
well.
well.
And it's a
And it's a
very
very
tight
tight
distal
distal
left main
left main
disease, which
disease, which
probably
probably
extends into
extends
the
into the
ostial
ostial
LAD and
LAD
the
and the
circumflex as
circumflex
well.
as well.
And
And
here,
here,
before the
before the
contrast is
contrast is
given
given
in,
in,
you
you
can
can
see
see
the
the
pacifications of the
pacifications of the
calcium.
calcium.
And over
And over
here, you
here,
can
you
see
can
on
see on
top that
top
it's
that it's
hanging by a
hanging by a
thread.
thread.
So the
So the
patient
patient
comes
comes
in for
in
an
for an
intervention,
intervention.
and
And
in this
in
kind
this
of a
kind of a
case,
case,
IVUS
IVUS
helps
helps
us to
us to
understand what
understand
we
what
want
we
to do
want to
with
do
the
with the
lesion.
lesion.
Here, the
Here, the
white
white
stuff
stuff
is the
is the
calcium
calcium
beyond which
beyond
you
which you
cannot see.
cannot
So
see.
there
So
is
there is
calcification in the
calcification in the
vessel,
vessel,
along with
along with
fibrous
fibrous
disease.
disease.
And this is
This
is in the LAD pulling back. And as we come into the left main here, you can see there is concentric calcification. It's a small vessel compared to the LAD, and you can't really see anything beyond. So there is dense calcification here. So this imaging modality tells us that we do need to modify the calcium for the stent to expand. Otherwise, the stent is not going to expand properly in the left main, which would not be a good thing. So we went ahead based on this imaging finding. We did cutting balloon angioplasty first to prep the lesion to make breaks in the calcification. So we used a non-compliant balloon and then a cutting balloon, and you can see over here that with the cutting balloon, it causes a dissection with a hematoma in the left main going into the LAD, and then you see this calcium chunk which is broken out, which means that we have been successful in making breaks in the calcium, and if we were to deploy the stent now, it would expand properly, which if you think about it, if there's calcium all around, then the stent is not going to really expand well. So now looking at this image, left is pre and the right is going to be post PCI, and you can see the difference in terms of the angiographic result as well, just in terms of how much good result we can obtain using intravascular imaging. Now going on to the second case, we have an 80-year-old male with past medical history of coronary artery disease, had a bypass graft surgery done in 2001, had a Lima to LAD, vein to OM, and vein to diagonal, had multiple PCIs to the right coronary artery, including the right PDA. Most recently, 6 months ago, underwent another second layer of stent placement. At that time, they had done intravascular lithotripsy with a shockwave balloon, and then also has hypertension, hyperlipidemia. He had rapidly escalating anginal symptoms refractory to medical therapy. Comes in for heart catheterization. I'm just going to go over the vessel of interest, where you can see that there's calcification and RC, the right coronary artery is basically just stented all throughout. You can see this area of constraint right here. If you focus on this part when it plays, which is the lesion of interest. So here, as I mentioned before, that for mechanism of stent failure, it would be important to image and know what's going on. And OCT would be the choice if the creatinine permits. And you can see the difference in the imaging quality for the IVUS versus OCT, with the near field is much more clear for OCT. The black spaces that you see is the calcification. So there is significant calcification around the vessel wall. And then here you can see these small lines are the stent. So you can see there are at least two layers of stent here. And then coming to the lesion itself is over here. And if you focus on the area, which is the minimal stent area, it's almost 2.3 millimeters square. This is where the lesion is, which is obviously secondary to an underexpanded stent with neointimal hyperplasia and neoatherosclerosis. So over here we decided to perform laser atherectomy with balloon dilations. In US, the drug-coated balloons are still not approved for commercial use, so it's still under investigational use, with data which is supposed to come out in the near future. So we just performed balloon dilations, laser atherectomy, we did brachytherapy, which is radiation, and then we repeated the OCT run and just going directly to the lesion itself over here. This is where the lesion was, and if you remember, it was 2.6 millimeters square, which is now all the way up to 5.7 millimeters square, which is the NSA. So there was a significant improvement in the NSA, and angiographically as well, you can see there was significant improvement in the flow going to the distal vessel. So again, another case where imaging helped us understand the mechanism of instant restenosis, helped us better optimize the results of the stent. Going on to the next case, we have a 68-year-old male with history of coronary artery disease, again CABG, had a vein graft to the LAD, which was occluded, vein graft to the RCA, which was occluded, and patent vein graft to the OM, had a PCI to the LAD with ISR, type 2 diabetic chronic kidney disease. He underwent a cardiac catheterization at an offset facility for ACS, found to have severe LAD ISR, and D-stenosis as well. He's being referred for a PCI. On admission, he's found to have an AKI with pyelonephritis with the creatinine up to 3.5. So this person is coming in with ACS, having worsening chest pain, even on a nitro drip. And I can show you the diagnostic images. So this is how the LAD looks. So it's hanging on by a thread over here. Distal, it's stented stenosis. There
There
is
is
ISR
ISR
within the
within the
distal
distal
stent as
stent as
well.
well.
Likely has
Likely
two or
has two or
three
three
layers of
layers of
stent,
stent,
but
but
has
has
AKI. So
AKI.
what
So
do we
what do
do?
we
Do
do? Do
we
we
let the
let the
patient
patient
write in
write in
pain or
pain
just
or just
medically
medically
manage, or
manage,
can
or
we do
can we
this
do
with
this
no
with no
contrast
contrast or
or use
use
contrast and
contrast
have the
and have the
patient end up
patient
on
end up on
dialysis?
dialysis?
So
So
this is
this
where we
is where we
use
use
IVUS.
IVUS.
Obviously, you
Obviously,
don't
you
want to
don't want to
use
use
OCT
OCT
because the
because the
creatinine is
creatinine
not
is not
normal,
normal,
and we
and
were
we were
able
able
to
to
balloon
balloon
dilate
dilate
just
just
based on
based on
IVUS
IVUS
imaging,
imaging, knowing
finding out
finding out
where the
where the
lesion is,
lesion is,
place a new
place a new
stent
stent
based on
based on
fluoroscopic
fluoroscopic
images,
images,
and
and
end up
end up
with
with
a
a
nice
nice
result, which
result,
I'll
which
show
I'll
you
show
on
you on
IVUS. So
IVUS.
this
So
is
this
the
is the
pre-PCI
pre-PCI
IVUS,
IVUS,
just
just
looking at the
looking at the
lesion
lesion
itself. And
itself. And
here,
here,
so if we
so
go
if we
back
go
here,
back
you can
here, you
see
can
these
see
are all
these are all
stent
stent
struts.
struts.
Then there
Then
is
there is
unstented
unstented
area,
area,
and then
and
this
then
is the
this is the
lesion where
lesion
there
where there
is
is
fibrous
fibrous
disease.
disease.
Again,
Again,
as
as
opposed to
opposed to the
first case
first
where you
case where you
saw,
saw,
you can
you
see
can see
beyond, so
beyond,
there's
so
not
there's not
significant
significant
calcification.
calcification.
So this
So this
helped us
helped
to
us
know
to
that
know
we
that
don't
we
really
don't
need
really
to
need to
modify the
modify the
vessel as
vessel as
much.
much.
And then
And then
again,
again,
coming up
coming
here,
up
there are
here, there are
multiple
multiple
layers of
layers of
stents.
stents.
So
So
we
we
placed a new
placed a new
stent. We
stent. We
just used
just used
IVUS
IVUS
imaging.
imaging.
Again,
Again,
absolutely
absolutely
zero
zero
contrast,
contrast,
not even a
not even a
single
single
shot to
shot to
visualize for the
visualize for the
PCI
PCI
itself.
itself.
And if
And
we
if we
keep playing
playing
this, you'll
this, you will
see
see
that
that
we
we
get a
get a
really good
really good
result with
result
the
with the
stent,
stent
with a good
with a good
MSA as
MSA as
well.
well.
And on
And on
the
the
right
right
picture, you
picture,
can
you
see
can
that
see
we were
that we
able
were
to
able to
pull
pull
the
the
catheter
catheter
back
back
all the way
all the
into
way
the
into the
left
left
main, and
main and
also
also
ensure that
ensure
we're
that
not
we're not causing any
any
damage to
damage
the
to the
left
left
main
main trunk
trunk
as
as
well.
well.
So
So
we
we
know we
know
don't
we
have to
don't have to
take
take
a
a
final
final
shot
shot
with
with
everything
everything
coming
coming
out,
out
because
because
IVUS showed
IVUS
us
showed
that
us
we
that
had
we had
created no
created no
damage and the
damage and
left
the
main
left
was
main was
intact with
intact with
no
no
dissection or
dissection or
hematomas
hematomas
or
or
perforations.
perforations.
So again,
So again,
this
this
kind of
kind of
is
is
probably one of
probably
the
one of
most
the most
important
important
things
things
that is
that is
upcoming as
upcoming
well,
as well,
where
where
interventional
interventional
cardiologists should
cardiologists
start
should start
becoming
becoming
comfortable doing
comfortable doing
PCIs with
PCIs with
absolutely
absolutely
zero
zero
contrast
contrast
if they are
if they
able
are
to
able to
get
get
access to the
access to
right
the right
imaging
imaging
tools
tools
in the
in
right
the right
patient,
patient,
as long as
as
we
long as
have
we have
diagnostic
diagnostic
images.
images.
So I'll
So I'll
quickly go
quickly
over
go
this
over
last
this last
case, which is
case,
a
which is a
43-year-old
43-year-old
male
male
coming in
coming in
with
with
crushing
crushing
substernal
substernal
chest pain
chest pain
radiating to the
radiating to
left
the left
shoulder. So
shoulder. So
very
very
typical
typical
ACS
ACS
presentation.
presentation.
And this is
And
the
this is the
ECG, where
ECG
you
where
can
you
see
can see
their
their
anterolateral
anterolateral
ST changes,
changes,
which are
which are
dynamic.
dynamic.
Within
Within
15
15
minutes, the
minutes, the
ECG being
ECG being
repeated, you can
repeated, you
see
can see
dynamic
dynamic
STT
STT
changes.
changes.
So
So
obviously in the
obviously in the
clinical
clinical
scenario,
scenario,
the
the
lab is
lab is
activated
activated
immediately.
immediately.
Patients brought to
Patients
the
brought to the
cath lab.
cath lab.
These are the
These are the
diagnostic
diagnostic
images,
images,
which you can
which you can
see
see
there's no
there's
real
no real
culprit
culprit
lesion, but there
lesion,
is
but there is
abrupt
abrupt
cutoff of
cutoff of
flow
flow
in the
in the
apical
apical
LAD and
LAD
some
and some
haziness in the
haziness in the
mid
mid
LAD.
LAD.
So we
So we
decide to
decide to
perform an
perform an
OCT
OCT
just to
just to
understand the
understand the
culprit
culprit
vessel
vessel
itself.
itself.
And this
And this
basically,
basically,
if you
if you
see,
see,
so this
so
is
this is
calculating the
calculating the
area,
area
that it's
that it's
6
6
point
point
or
or
5,
5
5
5
millimeter
millimeter
square,
square,
which
which
is
is
pretty
pretty
good.
good.
And then
And then
again, this is
again, this is
coming
coming
proximal.
proximal.
And
And
here you
here
can
you can
see that
see
there
that
is
there is
some kind
some
of
kind of
thrombus
thrombus
filled
filled
in the
in the
cavity,
cavity,
which
which
is
is
likely
likely
plaque
plaque
rupture.
rupture.
It's
It's
hard to
hard to
say
say
beyond the
beyond the
thrombus because
thrombus
you
because
can't
you
really
can't
see
really see
whether there
whether
is
there
a
is a
true
true
erosion or
erosion
a
or a
rupture, but you
rupture,
can
but you
see
can
that
see
there's
that there's
something
something
going on,
going
which is
on, which is
likely the
likely the
culprit
culprit
lesion,
lesion,
and this
and
might
this
have
might
just
have just
embolized
embolized
distally, which
distally,
led
which
to the
led to the
cutoff in the
cutoff in the
flow.
flow.
So in this
So in
kind
this
of
kind of
patient,
patient,
given that
given
we
that
had
we
good
had
flow,
good
we
flow, we
decided just
decided
to
just
treat
to treat
medically,
medically,
which
which
again goes
again
by
goes
the
by the
erosion
erosion
3
three
trial, which
trial,
was
which was
recently
recently
published,
published,
that
that
patients who
patients who
had
had
OCT
OCT
guidance,
guidance,
PCIs, or
PCIs, or
interventions
interventions
ended up with
ended up
less
with less
stents. So
stents. So
intravascular
intravascular
imaging does
imaging does
not mean
not
more
mean more
stents. You can
stents. You can
technically get
technically get
away with
away
less
with less
stents as
stents
well. as well. And just
just
to
to
show
show
that
that
you can
you can
still be
still be
okay,
okay,
and
and
just
just
using
using
intravascular
intravascular
imaging does
imaging
not
does
mean
not
that
mean
you will
that you
end
will
up
end
with
up with
additional
additional
stents.
stents.
So key
So key
takeaways here
takeaways
is
here
that
is
it's an
that it's an
important
important
tool
tool
before and during coronary interventions. One should always make sure when referring patients for a cardiac catheterization that the institute has all different imaging modalities with expertise in interpretation of imaging as well. Judicious use of intravascular imaging in the right patients can definitely improve PCI results. And I think PC most important for me has been that PCIs can be performed with zero or ultra low contrast in patients with kidney disease with the help of intravascular imaging. So just a couple of questions to go over. I know we're almost above time. So what imaging modality should be used for left main or aortoosteal lesions? OCT, IVUS, or no intravascular imaging? So over here, the correct answer is IVUS. Obviously, for left main interventions, you want to have some kind of intravascular imaging if the most critical vessel. OCT is not going to give enough blood clearance. You're not going to see the proximal vessel. So IVUS is the ideal, but if you don't have IVUS, if you can OCT, it's definitely better than no imaging. Which imaging modality should not be used in patients with advanced kidney disease not yet started on dialysis? IVUS or OCT. So should not be used. So you don't want to use OCT in patients who have not been started on dialysis yet, because again, OCT most important thing is that you will be giving contrast for OCT images. So with this, I would like to thank you all, and thank you for your attention.
So I'll be talking about multimodality imaging, echo, MRI, and CT in a valve disease and a case-based approach. I hope everybody had a good lunch, and instead of being sleepy, you're now energized to answer some of these questions. I have no disclosures. So audience poll, can you provide at least 3 indications of cardiac CT and cardiac MRI? This is a question I want you to ask yourself and try to answer as honestly as you can. Yes or no? 3 indications for cardiac CT and 3 indications for cardiac MRI. So this is great. We have 50% yes, 50% no. For the 50% yes, we'll start with some unique indications, and then for the 50% no, we'll go over the basic. So let's start with transthoracic echo. It's one of the core basics of imaging. Some of the uses are to assess mechanism and severity. So it's a primary modality to define the etiology and severity of valve disease, to look for coexistent valve disease, to assess the ventricular and atrial geometry, and to understand hemodynamics. The next is risk stratification. So you can get an idea of adverse chamber remodeling in the case of valvular dysfunction. You can get an idea of, is there ventricular dysfunction, and how are the hemodynamics? And then next is, does this patient need a procedure or intervention? So it helps in procedural planning. You can get confirmed hemodynamics for indication and for the intervention. So let's go with the first case. 30-year-old woman who is pregnant presented with some shortness of breath and was found to have a murmur. She underwent a transthoracic echo and was found to have a bicuspid aortic valve. No evidence of significant stenosis or regurgitation. She just delivered her baby now and is asymptomatic. What are the next steps? Cardiac CTA, cardiac MRI and MRA, transesophageal echocardiogram, or no further testing until symptoms develop. So you guys answered C. All of the answers could be correct for this patient, but let's talk about the most cost-effective one. Cardiac MRI and MRA, and I'll go over why. So this is an MRA, short axis of the aortic valve cine image showing the bicuspid valve of this patient. You can see that the left and right coronary cusp are fused, there's no raphe. So this confirms the bicuspid aortic valve. This is the long axis image. You can see that in the aortic valve and the outflow tract, there's some flow acceleration going on, but the valve is opening. The MRA showed us this information of coarctation of aorta. This would have been missed in the TEE. You would have gotten a good idea of the bicuspid aortic valve, which we already had from the transthoracic echo, which we can again confirm with MRI. So if you're looking for the most cost-effective test with least no radiation, then cardiac MRI and MRI would be good for this patient. Again, she's a 30-year-old female, childbearing age. You want to avoid radiation as much as you can. So remember, cardiac MRI for anatomy of aortic valve. Here I have MRI images of a quadricuspid, bicuspid, tricuspid valve. On the bottom, we have prosthetic aortic valves. This is how they image on the MRA. Look for coarctation with an MRA, and there's no radiation involved. So case 2, 85-year-old woman presents with shortness of breath and some chest discomfort. She had 2 recent negative stress tests. She undergoes an angiogram and has no obstructive or significant coronary artery disease. What are the next steps for this patient? Cardiac CT, cardiac MRA and MRI, transesophageal echocardiogram, or no further testing. So you can see something abnormal going around here. So a hint, these are the ribs. Ribs are bones and high calcification. This should give you some suspicion of calcification here. The correct answer is cardiac CTA, and we'll go over why. So this patient underwent a cardiac CTA. There was concern for calcification. So she has severe mitral annular calcification, also known as MAC, extending into the myocardium, also with a component of mitral stenosis. So these images are from a contrast cardiac CT, which was gated. So there were ECG leads attached. You could see the calcification also on the non-contrast CT, but again, you confirm it and see it much better in terms of the extent. If there's contrast, if there's caseation just like you see in tuberculosis, you can see with mitral annular calcification. So remember, cardiac CT is the best modality when concerned for calcified structures. You can assess the severity, exact location, and the extent in 3D views. Case 3, 63-year-old woman with a mechanical aortic valve replacement, 21 millimeter, St. Jude. Atrial fibrillation pacemaker, admitted with shortness of breath with acute decompensated heart failure. On transthoracic echo, she had prosthetic valve dysfunction, mild to moderate central aortic regurgitation, and severe stenosis. So peak velocity across the aortic valve was 4.3 meter per second. Mean gradients 43, peak gradients 74. Aortic valve area, which was calculated as 0.4. What is the next best step? Cardiac MRI and MRA, fluoroscopy or catheterization, transesophageal echocardiogram, or cardiac CT. So mechanical aortic valve, prosthetic valve dysfunction. So that you guys chose transesophageal echocardiogram. So now aortic valve is the most anterior structure. When you do a TEE, you're looking at from the esophagus. So the aortic valve is the furthest structure away, which is why cardiac CT here is the correct answer, and I'll go over the images. So this is what we found for this patient. Cardiac CT, she had mechanical valve thrombus. This is the quality of images we can get. So the black hypodense area here is the thrombus. We can see the HU, or the density of the material, which was 71, and that's how we identify it as thrombus. The next thing you want to see is this valve opening or closing okay? While fluoroscopy, or taking the patient to the cath lab, used to be the standard of care, this is the quality of images we can now get. And this is on a Siemens scanner. It's a good machine, but it's not even the latest technology. This is now a technology that's 15 years old. Again, these images can be post-processed to look like this, and here you can see this thrombus very clearly. We have a good audience here. How many of you think you could have seen this on TEE or in the cath lab on fluoroscopy, which was our standard of care? So remember, cardiac CT is the best modality when concerned for mechanical valve thrombus. You can assess the thrombus and the size. You can differentiate between pannus and thrombus, And you can measure the opening and closing angles for the valves for dysfunction. And these are examples of how you can measure the opening and closing angles. So back to the basics. CMR for comprehensive assessment of valvular regurgitation. What is the goal of imaging in valvular regurgitation? We want to look at severity. So we can calculate the regurgitant volume and regurgitant fraction by direct or indirect methods which don't involve complicated formulas like we do in echo. We can look at the consequence of the valvular regurgitation. So we want to know, even if it's visually severe or not severe, how has it affected the patient? What are the left ventricular and right ventricular volumes and function? Is the left ventricle dilated? Is there borderline reduced EF? Is there dilated left atrium? Is there progressive dilatation of the left ventricle and worsening of the left ventricular function? We can get an idea of etiology. Is this primary regurgitation or secondary? Is something inherently a problem with the valve, or did something else in the LV or the structure cause the disruption? What's the mechanism? Is there valvular prolapse? Is there degeneration? Is there flail leaflet? Is there a restricted leaflet? We can get an idea of the left ventricular viability and contractile reserve. It helps us assess the presence and location of the myocardial infarction on late gadolinium enhancement. I'll go over some examples. So in terms of mechanism of abnormality, on the left, we have a normal mitral valve. In the middle, we have posterior leaflet prolapse. And the third image is Barlow's leaflet with bi-leaflet prolapse. You can see how well we see the leaflet on cardiac MRI. Next, these are images of secondary mitral regurgitation, poor coaptation. You can see how the leaflets don't coapt, and you can see the regurgitate jet and how much area it covers in the atria. Again, this is non-contrast MRI images, and you can get a visual assessment, and then you can leave quantification to the experts. Next is ischemic chronic secondary mitral regurgitation. So in the long axis view, you can see how the inferior lateral wall is not moving at all. It is dilated, aneurysmal. You can see that there's tethering of this posterior leaflet causing the mitral regurgitation. This image here is post-contrast late gadolinium enhancement. You can see how the wall is thin, and this white area here is the infarcted myocardium. The complete wall has been infarcted. This black area here is the normal myocardium. So you get an idea of LV remodeling and scar assessment. Let's talk about cardiac CT for valvular disease. What are the goals of imaging with cardiac CT? We get an idea of pre-procedural planning. So understanding access planning. You heard a little bit about TAVR today. Similarly, there's mitral valve replacements. So by getting a cardiac CT, you get an idea of how are the arteries supplying, or the way your pathway that you're going to reach the heart, how are they doing? Implantation planning, including anatomy of the valve and surrounding structures. Prediction of complications. If you see a lot of calcification, you know that that patient's at high risk. Next is assessment of prosthetic valve. We went over an excellent example of how in prosthetic valve you can assess for thrombus or dysfunction. Infective endocarditis. You can look for extracardiac foci of endocarditis or infection. You can look for abscess assessment and pseudoaneurysm very well with cardiac CT. Again, you get a 3D data set. So unlike echo, where it depends on who took the images and how they took the images, in cardiac CT, you can go back and reconstruct all the imaging planes that you'd like. And then consequence. In cardiac CT, you can also get an idea of volume and function, and extracellular volume and function. Cardiac CT, however, is not the best modality because to get volume and function, there is a lot of radiation involved. So take-home message. Cardiac imaging usually starts with transthoracic echo, but does not end there. Cardiac MRI and cardiac CT are important adjuncts in valve disease assessment. Thank you.
Now back to the basics. I think all of you guys are probably doing on a daily basis. I don't have any disclosure, but I do have several cases. So this is a 65-year-old guy, history of CAD and the stenting of LAD, 30-pack years smoking history and still smoking. Shortness of breath is progressively worst over last 3 months. He has a clear sputum. History suggestive of PND and orthopnea. On exam, the heart rate is 105, respiratory rate is 22, blood pressure 120/80, pulse ox is 92% on room air. On exam, +2 pedal edema, S3 is present, no murmur, bilateral wheezing is present, and there is elevated JVD. So the question for you guys, what is the most likely diagnosis? I think you are seeing this type of patient almost on a daily basis. People did not vote. Anyhow, so I think that we will talk about the correct diagnosis, possible left heart failure, and I will say why. So just based on a clinical examination, I will say this one. So this was published in 1812, long or the way above, I mean way before the echo or the CT or MRI were available. And this is a still probably 100% correct description. The patient cannot breathe in a horizontal position. The pulse is frequent and weak. The veins are swollen in the neck. The strokes of the heart extend farther, which we consider as a heave. There is a swelling of the feet and ankles. I think this is a perfect description, was described probably 200 years ago. So Stephen Maggie is one of the best person, and he wrote this book known as Evidence-Based Physical Exam Diagnosis. So I know we have now not given a lot of importance to the physical examination. In fact, we are the one who were pioneer on all of those things at one point, and now I think everything is vanishing off. So I wanted to bring back our old memories. So what he did, he collected all the studies in which the physical exam findings or the history findings were mentioned, and then he collected and did a kind of a meta-analysis or the meta-calculation, and then he published this book, again, excellent book if anybody is interested to read, known as Stephen Maggie's Evidence-Based Medical Physical Exam Diagnosis book. So he, for example, for orthopnea, the likelihood ratio of left ventricular dysfunction or left ventricular failure is 2.7, and if orthopnea is absent, the negative likelihood ratio is 0.04. PND did not have exact the likelihood ratio available, but the signs of a transient pulmonary edema. And then what he did, from the likelihood ratio, he tried to calculate the possibilities or the probabilities. So these are a different likelihood ratios for a different findings, possibly for a heart failure. So heart rate more than 100, crackles, elevated JVD, positive abdominal jugular reflux, the supine apical impulses, S3, S4, and edema. And these are the important things he calculated. From the likelihood ratio, he gave a probability. You know, you can calculate a probability from the likelihood ratio. It's a mathematics, it's a simple math. So for example, if somebody has a positive abdominal jugular test, the possibility, the likelihood ratio is, for example, 6. The probability of that patient have a heart failure is 45%. On the axis, left axis it's a positive probability, left axis is negative probability. So from every single thing, for example, elevated neck veins, so the likelihood ratio is probably 4, the probability of having heart failure is 30%. So imagine if you combine the orthopnea, PND, the positive JVD, pedal edema, your probability of a heart failure is 80%. And I think this is very important, because a lot of time in a current world, what we are finding, patient does have a heart failure or not. No, echo is normal. And then we say, oh, there is no heart failure. How likely that the echo is going to be normal or abnormal, it's very important consideration. Crackles and the leg edema did not help. Another important point, he found out that the types of a crackles, I know we always have a little difficulty understanding, but at least just from the timing, for example, early inspiratory crackles versus the late inspiratory crackles. So if they are late inspiratory, more likelihood of pulmonary fibrosis, while if they are a mid-inspiratory or early inspiratory is COPD and mid-inspiratory is a heart failure. If you can take this message, will be very helpful when you listen to the patient on a daily basis. Early is COPD, mid heart failure, and a late is usually pulmonary fibrosis. And that I think can be very easily understandable. So I will encourage all of you guys to read that book. I just wanted to give a little synopsis. Second case, 60-year-old female with a progressive shortness of breath for years. Remember, these are the very important words. 30-pack year smoking history, quit smoking almost 15 years ago. going to the hydrotherapy or a pool therapy for chronic arthritis. On a physical exam, there is a late inspiratory crackles, more on the bilateral upper zone. These are a very important history findings. No wheezing, no gallop, no S3, no JVD, no heart rate, no hepatojugular reflux or pedal edema. Was treated as a COPD by the pulmonologist almost for 5 or 6 years with a salmeterol, fluticasone and thiotropium. Now requiring the oxygen for resting hypoxia for the last 6 months. This is a real patient I encountered. This is the PFT. I'm not sure that you can read the oh yeah, this is very small here. This is very good example. So what is the most likely diagnosis and what is the next best step of action? These are the important highlighted words that the patient has a progressive shortness of breath, hydrotherapy, late inspiratory crackles, and the PFT is showing, for example, FEV1 FVC ratio. The actual ratio is 85%, which is normal. Patient has a low TLC, meaning by showing the restriction. So the normal ratio kind of rules out obstruction. The decreased TLC is suggestive of the restriction, and DLCO is also reduced, suggesting of an impairment in the gas exchange. So what do you guys think the diagnosis is? Sorry? Say it loudly. Fibrosis of the lung. Okay. Yep. So the fibrosis of lung have a different flavors, but this was the next best step. I think is the investigation of choice is HRCT, high resolution CAT scan, which did show the reticulation and fibrotic pattern specifically in the upper lobe. You know, the trachea is not yet bifurcated, so that means we are still at the upper lobe. You can see the fibrotic bands, you can see the reticulation, you can see traction bronchiectasis. So this all findings were suggestive of hypersensitivity pneumonitis as a cause of the pulmonary fibrosis. Patient was sent for the open lung biopsy, and biopsy did actually prove the hypersensitive pneumonitis with a feature suggestive of a hot tub caused by the MAC, Mycobacterium avium cellulare. This was actually acquired while he was going to the pool therapy. So the pool therapy is actually one of the important reasons for people to develop MAC. BL also, the bronchoalveolar lavage showed MAC, and then the patient was treated for the MAC as well as for the hypersensitive pneumonitis with steroids, and patient was free of the oxygen, and patient was being treated as a COPD patient for the last 6 or 7 years, even by pulmonologists. So always, like, you know, all our ancestors taught, Milan Bhai is here, and I know that they are always teaching the value is always in a history, and I will still consider that despite of a significant advancement in the diagnosis, the value is still in the history and physical exam if we take a proper history. Every smoker does not always have a COPD, and clinical examination of still value. Third case, so 40-year-old female has a history of scleroderma limited to the skin and joint, progressive shortness of breath for 2 years, now not able to walk even a block. Exam is showing the SpO2 of 88% on room air, so quite hypoxic. Rest of the vitals are stable. On physical exam, the P2 is loud, right ventricular heave, no crackles and no wheeze. This was the PFT. I will give you just a second to read the PFT data. Remember, the important parameters in the PFT to look at are FEV1 FVC ratio, FEV1 and TLC, DLCO. If somebody asks me 4 things, these are the 4 things I will take a look at. So if I show you the PFT data, and then this is a question, what is the next best investigation for his shortness of breath and hypoxia? What is the next best investigation of choice? Okay, people said VQ scan, 2D echo and HRCT. So what is the diagnosis we are thinking here, just from the history and physical exam and the PFT? Probably pulmonary hypertension, and that's why the correct choice is the 2D echocardiography. So let me show you the important words here. Scleroderma. People with a scleroderma are very highly likely to develop group 1 pulmonary hypertension, which we'll talk probably tomorrow. Progressive shortness of breath, and hypoxia, loud P2 and right ventricular heave. On the PFT, you can see that the FEV1 FVC ratio is normal. The ratio is 83%. The patient has a TLC, which is normal, 86%, but the carbon dioxide or the DLC or TLCO, like in Europe, was significantly reduced. So when the patient does not have an obstruction suggested by normal FEV1 FVC ratio, when there is no restriction suggested by normal TLC, and if there is an isolated decrease in a DLCO, There are two important causes. The one is a pulmonary hypertension and second is anemia. I think in India, anemia will definitely be very important, but you can get a corrected value of anemia for the hemoglobin. Despite that, if the DLCO is low, you have to think of pulmonary hypertension, and the screening investigation of choice is 2D echocardiography. Of course, this patient had a significant RA, RV enlargement, and we did talk about a classic pulmonary hypertension diagnosis. So patient had a right heart cath, suggestive of pulmonary arterial hypertension, so patient should be considered for the vasodilator therapy. This is a last case for acute dyspnea, not the chronic. So the chronic we talk differently, acute we talk differently. So this guy who is a 55-year-old person who has taken a flight recently from Italy to, for example, New Delhi, and he has a shortness of breath only for 2 days. 20-pack years smoking history, recently diagnosed to have a COPD and recently diagnosed to have a non-small cell lung cancer. On admission, the vitals were 120/60, heart rate is 114, pulse ox is quite low even on a 3-liter nasal cannula. Exam is not showing any crackles, no S3, EKG is normal, chest X-ray is showing hyperlucency, hyperinflation, and COPD suggestive of changes. So the question for you guys again, what is the most likely diagnosis? Acute P, right? I think this is a pretty straightforward, I guess we can stop it, that's fine. So we do probably 40% more CT scans. Why do you guys think this guy is a PE? Like, what did you calculate? I think all of you guys are an excellent clinician, but if you translate, for example, every time the PE comes into the picture, I would urge people, all the trainees and even clinicians, to do like a VAL score, for example. The VAL score for the PE and a VAL score for a DVT. So if we translate the VAL score, the clinical signs and symptoms of DVT in this patient, no. The PE is the #1 likely diagnosis, and this is the most catchy part. So that's why I wanted to show you this one. Why we think the PE is the most likely diagnosis. Patient is hypoxic, acute chest pain, acute shortness of breath. Chest X-ray is normal. Yeah, chest X-ray is normal. I think that is one of the key features. It won't explain you the hypoxia. That's why I gave you a normal or the hyperlucency suggestive of chest X-ray. So I think here we can put a 3-point, heart rate was more than 100, so 1.5 point. Immobilization or the surgery, I mean, he took a flight without any break. I think that was the immobilization or the static component. Rest of the criteria is negative, so his pre-test probability is around 26%. So that's why I think all of you guys have done this thing. I'm not sure that here what is a practice, but in United States, anybody comes with a shortness of breath or a chest pain, probably more than 50 or 60% of the people go through the scanner. They will do a CT scan just to rule out PE, and 80% of those CT scans will be negative. So this is one of the important take-home message, that every time you think of a PE for acute shortness of breath, please try to calculate the VAL score. Yes, of course, he had it, the PE. So in conclusion, for causes of the acute shortness of breath, you can have acute PE, acute exacerbation of COPD or asthma, pneumothorax, acute heart failure or the exacerbation of heart failure, possibly due to MI or arrhythmias, acute pneumonias. And in those cases, treat in conjunction with investigation, because we may not have a time to do everything. Sometimes patient like you try the treatment of PE and start the treatment of pneumonia if you are in a doubt. While for a chronic shortness of breath, which is over weeks to months, the usual diagnoses are completely different. For example, left heart failure, COPD, not the exacerbation, asthma, interstitial lung disease, and pulmonary hypertension. So usually we try to first diagnose the entity and then treat, not simultaneously you treat 5 things. With that, I will say thank you very much, and I'm happy to answer any questions.
So let me assure that all of us are awake. So let's do one small exercise. Let's stand up at the place, those who can. हाथ फैलाओ और ताकत से हंस लो. That's a good exercise to make us happy and awake. So for next 12-13 minutes, I request you one thing. Please forget the word hypertension. We are just talking about blood pressure. Even I will not use that word as far as possible. Maybe at 1 or 2 places I may use. But look at blood pressure as blood pressure and not hypertension, because to understand a new concept, it's very important that we delete the old concept. So we have known a lot of things about hypertension, we have discussed it a lot, and then perhaps the mind is so much into hypertension that we have overlooked so many important points. Maybe many of you will question that blood pressure has been existing for hundreds of years. We have been treating for more than 20, 30, 40 years blood pressure, and still you are coming out with a topic that so many things which as a physician we do not know about blood pressure. So I'm very sure it will be very interesting. Now, before I go to question and clinical case, let me give you 2-3 important slides and informations. Based on observations of the world over a period of hundreds of years, a lot of data has been collected in terms of prospective cohort studies, and these studies have shown very important point. There is a continuous log linear association between blood pressure and cardiovascular event. What do I mean to say that? When the blood pressure increases, the risk of heart attack, stroke and death increases. And this has been seen across diverse populations, whether it's men or female, all ages starting from 20 years to 90 years, those who have got established cardiovascular disease or those who do not have cardiovascular disease, and across different ethnicities. So one thing which we have observed over a period of years is, as the systolic or diastolic blood pressure increases in a linear fashion, the risk of cardiovascular disease increases. And we also know that, you all know this, that risk of cardiovascular event starts at a BP of 115 by 75 millimeter of mercury, maybe even before that, and it doubles with every 20 millimeter increase in systolic blood pressure and 10 millimeter increase in blood pressure of diastolic. So this is a fact which we have all known. Now still, even though we know this, the risk starts at 115 by 75 or before that, why have we defined hypertension at a level of 140 by 90? If you look to the latest European Society guideline, it is 140 by 90. Indian guidelines also follow European guidelines saying 140/90. I'm very sure US people are much wiser than many other people on this earth, and they have taken the definition to 130 or 80. But still, we are saying that blood pressure or hypertension starts at 130/80 or 140/90, while in fact, if you look to the previous slide, your risk of heart attack has been always by this time 2 to 3 times higher, because risk of hypertension, risk of stroke, MI and death starts at 115. So by reaching 140, where you are not getting treated, even when a patient reaches a blood pressure of 140, comes to your clinic, you will generally try the lifestyle modification first for maybe 2, 3, 4, 6 months, because a figure of 140 is not giving that serious most alarm to your brain. You believe that it's okay, it's fine, because hypertension, it is just mild beginning of hypertension, while as a matter of fact, the risk of heart attack and stroke has already increased to 3 times. Again, what about the goals? Once your blood pressure is more than 140/90, you waste a lot of time in lifestyle and other aspects, and then if it is not controlled, you may start treating, and again your goal is to go to less than 140/90. You never talk about going to 110 by 70. Why? Are there no extra benefits? Because as you rightly know that the risk starts at 110 or 115 or maybe 100 systolic BP, but when you talk about treatment of blood pressure, you just say that let's get the pressure down to 140/90. Why? Why don't you make the blood pressure normal of a person who has come to you, whose entire purpose is to reduce his or her risk of heart attack, stroke and death? He is not asking you to reduce his blood pressure. He is begging that, doctor, reduce my risk of heart attack and stroke, and you are getting his blood pressure to less than 140/90 and do not think to get it to 100 and 110. Why? What are the reasons? So with this basic understanding and questions, let me put the first case scenario. You should be ready here. Voting pad should be ready. Question 1, who has higher future 10-year risk of MI, stroke, heart failure and cardiovascular death? Number 1 patient is Mrs. X, 51 years, blood pressure is 162/92, mild obese, no diabetes, no smoking, no history of cardiovascular disease, ejection fraction normal, total cholesterol 150, LDL 95, HDL 40. So this is one lady, 51 years with hypertension. There is another gentleman, 67 years, blood pressure is seemingly normal, 130/78, mild obese, no diabetes, smoker, no history of cardiovascular disease, pumping normal, lipid profile the same. So B option, and option C is both have the same future risk. So your time starts now. So it's almost divided, but many of you have perceived that both have the same risk. Now let's see what actually is. If you put this to ASCVD risk calculator, the risk of first person, this is the lady of 51 years, is 3%. The risk of second gentleman is 18%. So both of them do not have same risk. The number 2 gentleman, as far as risk of heart attack and stroke is concerned, has got 6 times more risk than the lady who has got a BP of 162. So your eyes and brains are habituated to estimate the risk of a patient based on only one risk factor. So if you see the blood pressure elevated, you believe the risk is high, but your eyes and brains are not able to accept the other factors which bring in the risk. That is age, that is gender, that is lipid profile, that is smoking. We do believe that based on risk factors, we are able to assess the risk, but actually see, if you look to your answer, we have not been able to assess the risk rightly well in these patients. So let's go to question number 2. Whose blood pressure would you like to reduce by giving antihypertensive medication? Same the first lady 162 by 92, same the gentleman 130 by 78 with smoking, none of the above, both of the above. Whom would you like to give blood pressure medication? Your time starts. So many of you took it right that both of them need reduction in blood pressure to reduce their risk. Many of you have suggested that it is only 162 which needs to be reduced. Somebody whose blood pressure is 130 having high future risk, blood pressure reduction doesn't help. So those people who are 31.5% people believe that in this gentleman whose blood pressure is normal, though his future risk is high, if we reduce his blood pressure, we are not going to affect his future risk. And then third and last question for this talk is, question 3, whom would you like to give statin medicines? Again, the first lady, 162 by 92 BP. The second gentleman, again the same gentleman, none of the above, both of the above. Your time starts now. So good, most of you believe both of them. So it means statin has been well accepted in your mind that it is a risk reducing medicine irrespective of the lipid profile. Is it right? Because lipid profile is seemingly okay for both of them, but still you believe that by giving statin and by reducing LDL cholesterol, you are going to reduce further risk. But your brain doesn't know that by reducing blood pressure to both of them, you are going to reduce their risk. So that is something which I would like to teach you in next 4 to 5 minutes. So there was a beautiful meta-analysis produced in Lancet before 5-6 years, more than 6 lakh patients. And they were the patients whose blood pressure was ranging anything between 100 to 180 millimeter of mercury. So there were people who were hypertensive, there were people who were normotensive, and what they wanted to find out is, what is the cardiovascular benefit when you reduce systolic BP by 10 millimeter of mercury? That was the first question. And what they found is, when you reduce systolic blood pressure by 10 millimeter of mercury, you reduce major adverse cardiovascular events by 20%. So when you reduce 10 millimeter of blood pressure, you are going to reduce risk of a patient. But the second point, which is very important, what is the importance of blood pressure? Does this risk reduction applies to only people who are hypertensive, or does it apply to anyone and everyone? And the answer to your surprise was, the benefit is across the spectrum. Even if your blood pressure is more than 160, you reduce it by 10, you get 20% MACE benefit. If your blood pressure is 130, you reduce it by 10 millimeter of mercury, you get 20% benefit. If your blood pressure is even 120, you reduce it by 10 millimeter of mercury, your severe risk is going to be reduced. So even a person who may not be a patient, even a person, it may be you, it may be me, it may be a person without disease, without diabetes, without smoking. When you reduce 10 millimeter of mercury blood pressure, you reduce risk of cardiovascular disease by 20%. Simple. So this is a very important fact. Another data, again from the Lancet, 67,000 participants. And here they divided the people into their future cardiovascular risk. No, nothing about blood pressure. They were hypertensive or normotensive, they were smokers, diabetes, no diabetes. They just took people and segregated them into 4 risk categories: less than 10%, 10 to 15%, 15 to 20, and more than 20% as far as future risk is concerned. And what was found, when you reduce 5 millimeter of mercury systolic BP, there was 15% risk reduction in 3-point MACE. So again, whatever your baseline risk is, you may be a low risk person, you may be a high risk person, you may be a intermediate risk person, but whenever your blood pressure is reduced, you are going to get benefits. Say for example, you are a 25-year-old boy, you have 115 blood pressure, you are not a smoker, no family history, no diabetes, no cholesterol, nothing. You are a very low risk person, your future risk of heart attack is 1%. Even if you reduce your blood pressure by 10 millimeter of mercury, that 1% risk is going to be reduced by 20%. So that benefit is happening to everyone. So these two beautiful facts have been established. If you look to your right hand, when you reduce LDL cholesterol by 40 milligram, you reduce cardiovascular risk by 20%. Similarly, when you reduce your systolic blood pressure by 10 millimeter of mercury, your risk reduces by 20%. So same equation, you reduce LDL cholesterol by 40 milligram, you reduce blood pressure systolic by 10 millimeter of mercury, both of them give you equal benefit. So it is not only statin, it is also simple blood pressure reduction, which gives equal benefit like statin. Second beautiful truth is irrespective of the baseline LDL cholesterol, and here it is irrespective of the baseline SBP. And to your surprise, as we know that in cholesterol, there is no lower limit identified. You reduce your LDL from 160 to 120, there is benefit. 120 to 80, there is benefit. 80 to 40, there is benefit. And make 40 to 0, perhaps there is benefit. So similarly, when you reduce blood pressure systolic from 120 to 110, there is benefit. From 110 to 100, there is benefit. From 100 to 90, there is incremental benefit. Yes, in blood pressure, there is one additional point that you have to be clear about postural giddiness, CNS perfusion, and kidney perfusion. So what should be the approach in next 2 to 3 slides about conclusion? Your patient needs measurement of blood pressure as well as CV risk assessment. So whenever you see anybody in your chamber, don't concentrate only on blood pressure. Think as a CV risk and entirety, and which are the patients where you should be aggressively treating blood pressure. All those who come to you with a BP of more than 160. BP of more than 160 can be the severe most blood pressure. It is not stage 1 BP. Previously we used to believe up to 140 we are normal, 140 to 160 is stage 1, 160 to 80 is stage 2. By 180, many people will die and will have heart attack and stroke. You cannot wait till that level. Once you have touched 160, you have crossed the limits of danger. You have to get blood pressure to less than 120. Second, even if your blood pressure is normal, maybe 120, 115, 125, your measure risk of ASCVD risk of next 10 years. You do not have a calculator, don't worry, think of multiple risk factors. If you have got multiple risk factors or you have got established atherosclerotic cardiovascular disease, whatever your blood pressure is, reduce it by at least 10 to 20 millimeter of mercury. So those senior citizens who are sitting here, blood pressure may be 120, but those who is aging 70, his or her risk of cardiovascular disease is 30% in next 10 years. Reduce from 120 to 110, believe me, you are going to get benefit as far as reduction in risk is concerned. Step 3. If you do not have calculation of risk, your blood pressure is even normal, go for CT coronary calcium score. If your CT coronary calcium score is more than 100, surely you need to reduce your blood pressure by 10 millimeter of mercury. So what I'm expecting in future, these are the guidelines about LDL cholesterol, that those people who have got low risk of future event, your target is 115. While those people whose risk for future event is very, very high, means those who have got recurrent MI, recurrent events, their LDL target is 50. Similarly, blood pressure goal cannot be made unified for everyone. Blood pressure goal depends upon your risk, not blood pressure. Mind well, your blood pressure treatment goals doesn't depend on your blood pressure values. They depend on your what is risk. If your risk is mild, it's 140. If your risk is severe, and see, believe me, forget about patients. Maybe 30 to 50% people sitting here, they may fall into high risk categories. So they have to target BP of 110 by lifestyle, and if not, by medications. So coming to carry home message, don't look at the only BP values, look at the overall risk, because we know that risk starts at 115 by 75. When you reduce systolic BP by 10 millimeter of mercury, you are reducing risk irrespective of your baseline blood pressure. Rather than treating only BP values, treat the patient and his risk. Need to personalize the BP goals. You cannot drive everyone with the same stick of 140/90. Those who have got high risk, even if his blood pressure is 120, you need to treat and reduce. And achieve systolic blood pressure of less than 120 or even less than 110 in people who are normotensive but have got sufficient high risk. Thank you very much.
So here what I am going to give you an overview of the how to manage a pulmonary embolism, whether it's an acute pulmonary embolism or it's a chronic pulmonary embolism. So let's see one case. It's a 52-year-old male. He came with a short history of dyspnea on exertion. He was obese and diabetes. He could not able to walk for a few steps also, and once he had fallen because of the suffocation or fainted, and he was admitted in the periphery and was given the primary treatment as a IHD. And but he was having a progressive dyspnea, and he was referred to CIMS Hospital. Here I found on the ECG there was a sinus tachycardia with some STD changes, and heart rate was 120, SpO2 was 85%, and BP was on borderline 90 by 56. ECG was showing RBB, and there was some STT changes, and echo was suggestive of severely dilated RARV, severe PH, RV dysfunction with apical sparing. So if this history and this diagnosis, you don't need any other diagnosis, it has to be acute pulmonary embolism, which was treated like a ischemic heart disease. The pulmonary angiography was done straightforward, at which revealed the massive pulmonary embolism. Patient was thrombolized with alteplase, and subsequently he was started on the NOAC, and the Doppler shows the deep vein thrombosis of the pelvic vein. Second patient, she was 82-year-old female, just recently came to our hospital. She had operated for the hip fracture, and she was immobilized for 15 to 20 days, and she was comfortable on the bed, but with the minimal activity, she used to feel dyspneic. Her heart rate was 107, SpO2 was on the lower side, and with O2, the SpO2 came up to the 93%. BP was 110 by 70, ECG was suggestive, incomplete RBB, echo suggestive of mildly dilated RRB, there was moderate pH, venous Doppler suggestive of the DVT of the right leg, and D-dimer was 9,000, more than 9,000, and creatinine was 1.8. So this patient, what I did not do the pulmonary angiography because creatinine was on the borderline. She was 83-year-old female, and echo was very much suggestive of the acute pulmonary embolism, but she was stable. The third patient was 25-year-old male, acute DVT of left lower limb followed by pulmonary embolism, was managed with the IV thrombolysis, heparin, and subsequently by oral anticoagulant. Acute DVT was settled with the medical treatment. Subsequent echo parameters were normal, and he was put on the oral anticoagulant. But subsequently, prothrombotic workup was also done because he was very young and it was all normal. But subsequently, he started developing dyspnea on minimal exertion. Over the 1 or 2 years, he became so dyspneic. And when we did the echocardiography, there was suggestive moderate to severe PH, dilated RARV, and we put on the newer treatment for the pulmonary arterial hypertension, and repeated pulmonary angiography was suggestive of severe thrombosis in the pulmonary artery, and I kept him on the double antiplatelet also, oral anticoagulant also, but symptom continued to worsen. So looking to all the three scenarios, one patient was having classical pulmonary embolism, the second was having the submassive pulmonary embolism, and third was the acute pulmonary embolism complicated by the CTEP. CTEP is chronic thromboembolic pulmonary hypertension. So are the management of all these patients are same? No, there has to be some different. What happened to this patient? Because acute pulmonary embolism in the first patient was secondary to the obesity and the pelvic DVT. The second lady, elderly lady, was bedridden because of the surgery, and she developed the submassive pulmonary embolism. The third patient was quite young patient. He, in spite of giving the NOAC and appropriate medical therapy, used to have the chronic showering of the small or microthrombi in the distal pulmonary embolism, distal pulmonary tree. That's why he developed the chronic thromboembolic pulmonary disease. So there are some newer risk factor which also considered to be a risk factor for the pulmonary embolism, like hospitalization for the heart failure, patient with atrial flutter fibrillation in the past 3 months, patient with recent myocardial infarction in the past 3 months, patient with the previous thromboembolism. So these are considered to be a newer risk factor. Even patient with the orthoscopic surgery, patient with immunocompromised patient, patient with congestive heart failure, respiratory failure. Recently, we have seen 2 or 3 females underwent the in vitro fertilization. They presented with the pulmonary embolism. So these are the newer risk factors where we have to keep in mind, because pulmonary embolism is a diagnosis of suspicion. It's not a diagnosis of exclusion. So Dr. Recently, just last lecture, I think Dr. Bhavin has suggested that Wells score is a very good Wells score. Whenever you are suspecting pulmonary embolism, like just see the clinical parameters, sign and symptoms suggestive DVT, and patient is having severe tachycardia, immobilization for 3. So any of the 2 or 3 are there, there is a high suspicion of the pulmonary embolism. So pulmonary embolism is a diagnosis of the suspicion, not the diagnosis of exclusion. The other criteria like Geneva score criteria, again they are very easy. Based on this criteria, you can suspect whether patient belong to a high risk category, intermediate category, or the low risk category. So whenever you see a patient with suspected pulmonary embolism with shock, directly this patient should go for the CT pulmonary angiography, and based on that you can decide the treatment. If CT pulmonary angiography is not available, just get the echocardiography done. If RARV is dilated, just treat on the line of pulmonary embolism. And If patient is not in the shock and you don't have the facility of the CT pulmonary angiography, just get the echocardiography done, just get the D dimer. If D dimer is negative, you almost rule out the pulmonary embolism. But if the if the D dimer is high and echo is suggestive of the like dilated RRV and CT angiography subsequently suggests the pulmonary embolism, we have to treat like a pulmonary embolism. So D dimer is a very good tool to rule out the acute pulmonary embolism. So recently there is one risk score, the passive risk score. Based on that also we can suggest whether this patient is intermediate risk group, high risk group or the low risk group. So in your clinical or emergency setting, everything you should be knowing what are these criteria to diagnose the pulmonary embolism. CT pulmonary angiography is the gold standard for the diagnosis of pulmonary embolism. But yes, sometimes echocardiography will give you a very good hint, and based on dilated RARV, presence of thrombus in the main pulmonary trunk, you can diagnose the pulmonary embolism. And there are 2-3 articles available. If at admission, if RRV is dilated, the ratio of RV to LV is less than 0.9. That again suggests a bad prognosis. And at discharge, if RV is not settled, RV to LV ratio is more than 0.9, less than 0.9. That means patient has a poor prognosis at the 3 months. So again, when you see or look at the parameter, RV dimensions are very, very important. How to manage a massive pulmonary embolism? Give anticoagulation like unfractionated heparin, lower molecular heparin we can give, thrombolysis we can give, and some patients are even can give in the local thrombolysis, embolectomy also we can do, but some to a selected patient. So thrombolysis is a good list of all the thrombolysis agent available, but mostly in the current era, we thrombolyze this patient with either alteplase or the tenecteplase, and both are available, very easily available with all the pharmacy. And at all, if you want to give the low molecular heparin, give in the proper dose. What I have seen that patients treat half-heartedly. They don't give the full dose of low molecular heparin. So the ideal dose of LMWH is 1 milligram per kilogram twice daily. So if at all you are giving, give in the proper dose and the full dose. And the data has suggested that those patients who underwent thrombolysis, their PA pressure drops to a significantly. So whenever you are seeing a patient with a pulmonary embolism, though the patient is stable, but if there is a RRV dilatation, if the patient is clinically little bit unstable, the thrombolysis is the choice. And some patients, they are not suitable candidate for the thrombolysis or failed thrombolysis. We can even do the mechanical fragmentation. There are some device available, hydrodynamic fragmentation, ultrasound accelerated fibrinolysis, and suction embolectomy. These are all fancy devices, but yes, sometimes we can use all these fancy devices. Some patient may need a surgical treatment also, like patient in the cardiogenic shock, not recovering with the other therapy, then we can send this patient for surgery. Patient with the RV dysfunction, significant myocardial injury, these patients do better with the surgery. We can just remove the pulmonary embolism from the pulmonary tree, and these patients do better. What about the submassive pulmonary embolism? They usually need anticoagulation, they don't need the thrombolysis, but yes, there are some data that submassive pulmonary embolism with dilated RARV, with borderline hemodynamics, if you thrombolyze those patients with even the half dose of thrombolysis also, they patient do better in the long term. So if patient is stable submassive pulmonary embolism, you can thrombolyze with the half dose of TP or alteplase, and these patients do better on the long term. What about the management of CTEP? It's a unique form of pulmonary hypertension where you can give a definitive treatment to this patient. What I told that CTEP, why they develop? Because there is a chronic showering of the thrombi into the pulmonary tree, which lead to the chronic thromboembolic pulmonary. And this is the this diagnosis can be done by VQ perfusion, ventilation perfusion mismatch. If there, we diagnose the CTPH. And this disease, this problem can be very well treated with the surgical pulmonary end arterectomy. This is the one patient where the cast has been removed from the whole pulmonary tree, and this followed by the medical treatment. Almost 50% of patient responds with the surgery. And morning Urmil was talking about the other available treatment for the pulmonary arterial hypertension. We have all things available. So surgery followed by good medical treatment, these patients do very good in the long term thing. So right now we have available so many new cetuximab is now available, and then this macitentan is also available. So newer things are easily available nowadays. So we should try to give optimize the medical treatment for these patients. This is just a picture of one patient who was treated at the CIMS Hospital. My patient, she was having severe pulmonary hypertension, and because of the CTPH, her PA pressure, you can see 91/37 pre-operatively, and this patient underwent, this cast was removed from the pulmonary tree, and the subsequently post-surgery, the PA pressure has come down to absolutely normal, and now this patient is absolutely fine. So, again, treatment is important, but how long you have to continue the anticoagulant, that is again very important. If you see a patient with DVT or pulmonary embolism unprovoked, first provoked, like because of some surgery or some predisposing factor, give anticoagulant for almost full 6 months, and first provoked with the upper extremity DVT, again give anticoagulant for 3 months, and second provoked, give for the 12 months, or some patient may need a indefinite duration. Again, if patient is having recurrent pulmonary embolism, these patients are candidate for the indefinite treatment of anticoagulants. Patient with a cancer or patient with a provoked DVT, we can stop the anticoagulant after 6 months. IVC filter do not require for all the patients, but yes, some patients where they have contraindication with oral anticoagulation or NOAC, or some patients are not responsive with even giving the high dose of the oral anticoagulant, or some patients they not respond or in spite of giving this thing, then this IVC filter is indicated. So treatment of DVT along with the pulmonary embolism, very, very important. You have treated the pulmonary embolism, but you have not given the attention for DVT also. It's not good, because long-term DVT lead to the CTPH, and subsequently patient develop the severe pulmonary arterial hypertension, or not the CTPH, but this patient may develop the post-phlebitic syndrome. This patient may develop the varicose vein, and that can be troubling in the long term. So treating a good DVT, treating a DVT with pulmonary embolism, and long-term treatment of DVT is very, very important. And which I said that giving the anticoagulant, give in a proper dose, give in an adequate dose, so the patient responds to better. And these are the list of NOAC available, dose and everything you can find out the internet, warfarin, dabigatran, rivaroxaban, apixaban, all are available nowadays, and you can choose whichever you want to give, and give in the proper dose. So how my patient did, all my 3 patients, the first one acute pulmonary embolism, managed with thrombolysis, continued on the NOAC, and now he is doing good. The second patient that was 83-year-old lady, she was having submassive pulmonary embolism. She was diagnosed with the symptom and the echocardiography. Pulmonary angiogram was not done because of her borderline creatinine, and she is also fine. The third patient, acute pulmonary embolism, complicated by CTPH, underwent pulmonary endarterectomy, and she is also now doing good, and she is coming for the regular follow-up. So pulmonary embolism can present in 3 ways: non-massive, low risk, just give some anticoagulant, and then okay, submassive, if patient is having RV dysfunction, elevated biomarker, thrombolyze this patient with a half dose maybe, and massive pulmonary embolism, they fall to a very high risk category. And these patients, they require either thrombolysis with the TPA or TNK TPA, or if they are not indicated, they are not candidate for the proper thrombolysis, then you can do the catheter-directed thrombolysis for all these patients. Thank you so much.
I think so. The controversy continues, and my talk is again a very controversial talk. Still a long debate, and this debate goes everywhere. In whatever conferences you go, still in our cardiac surgical forum also, this debate is still going on. Searching for the second best conduit in CABG. Is there any silver bullet? And I think so what is happening is, this is the situation everywhere. Whenever the patient comes, after a good amount of shopping, this is what they say and they demand. मेरे को ये करके दो, मेरे को इसी तरह से surgery करवानी है. That is what happens is. But actually, it is not the situation. I have no disclosure, but I would like to show my data that what sort of CABGs that we are doing at our center. I would say almost 88% of the bypass surgeries that I perform will have multi-arterial grafts, of which almost 50% of the patients will have total arterial bypass grafting that we do at our center. Only 12% of the patients will have lima with venous graft at our center. This is our data of last 1.5 years of almost 1,226 patients. And Clifford Barlow has said, CABG conduit choice must be based on best evidence and not what is convenient, comfortable, and profitable for the surgeon. And the idea of using multi-arterial grafts in CABG is certainly not new, and it was there in even 1970s and 80s. And this is the first paper that was published by Loop in 1986, where it showed there is significant advantage of
multi-arterial bypass graft. But this is the recent analysis that was presented by STS database, and what they showed is, in spite of the data, in spite of the literature available, only 22% of the patients are still getting bypass surgery with the multi-arterial grafts. And the reasons that they have quoted for not doing multi-arterial grafts are very many, and that is a debatable points. And if you look at the data across the European countries, across the Canadian continent or the US continent, still the multi-arterial grafts are done in almost 11 to 22% of the patients. The highest is probably in Japan data, wherein they do 22.7% patients they receive multi-arterial or all arterial, total arterial bypass grafting. So what are the factors which are considered when you're using conduits in a CABG? There are many factors that needs to be taken in consideration, like age, sex, diabetes, LVF, obesity, target vessels, quality of the conduits, renal dysfunction, osteoporosis, emergency elective pressures, peer pressures, choices, patients' choices, and expertise and infrastructure. And last but not the least, now the biggest factor is definitely the government policies that are there. And last, very important issue that is coming up in the recent time is the financials. So let us consider a case, a male patient 60 years of old with TVD. Now there can be two categories of patient. One patient is no diabetes, normal LV function and lungs are normal, no obesity. Whereas there is another 60-year of patient having uncontrolled diabetes, 25% of EF, chronic smoker, and BMI is 30%. So when you are treating these two patients, your strategy, your management will be totally different, and you have to decide based on the profile of the patient. We all know by default any patient who is undergoing bypass surgery, Lima to LAD is the golden graft. Without that, a patient should not come out of the OR except in very rare scenarios. Reason being is 90 to 95% 10 to 15 year patency rate, and the patency rate, the advantage that you get is always in the second and third decade of surgery after bypass surgery. Very important thing to be noted here is the inferior rates have been documented with mammary artery is placed on right coronary artery. This is a well documented evidence that we have. But one thing is very sure, Lima to LAD is the magic wand. So which are, and another reason why Lima to LAD is important is because it supplies the 60% of the LV, LAD artery. So majority of the myocardium is taken care of by Lima to LAD. So what are the other conduits that we have? That is saphenous vein graft, radial artery, and right internal mammary artery, and gastroepiploic artery, which not routinely used everywhere except in Japan. Right internal mammary artery is definitely a twin sister of Lima. So all the characteristic and all the advantage that we have are the same with both the arteries. Another is the saphenous vein graft, which is, I would say, the 95% of the bypass surgery patients will have a saphenous vein graft, and the patency rate is in the range of 50 to 60% at the end of 10 years. But very important thing is, this is the conduit we have in plenty. Second thing is, it is a passive conduit, it is not a dynamic conduit, so that can be used in very worst case scenario or where the lesions are not very critical. Radial artery, a very challenging and a very good conduit which can be used, and in 80 to 90% of the cases it remains open at the end of 10 years. But yes, its utilization is still less across the world. So what does the literature review says? There are n number of literatures available, but what we have gone through is 11 randomized trials, 25 retrospective and cohort studies, and 3 meta-analysis studies that we have analyzed and seen. Obviously, there are limitations of RCTs and observational studies. And this is a very landmark paper published in 2014, which suggests that an SVG was significantly associated with 4-fold or 3-fold increased risk of late functional graft occlusion when compared with RIMA and radial artery. Similarly, this also fixes this thing. Yes, multi-arterial grafts are better than only the venous graft. So one thing is very clear. Any patient undergoing bypass surgery, if all the parameters are fine, that patient should get a multi-arterial graft. Whether it is 2 or 3 is indifferent, but yes, minimum of venous graft. So no doubt about it. And this is the meta-analysis which has shown that at the end of 15 years, if the patient is male, female, or age less than 65, more than 65, diabetes, chronic lung disease, renal disease, or anything. So practically the whole subset of patients, they benefit by getting multi-arterial grafts. So there is no doubt about it. So take home message, any patient referred for bypass surgery should get a multi-arterial grafts. What about BEMA grafting? Way back in 1986, Bruce Lytle, in his very, I would say, epic paper from Cleveland Clinic, has suggested that by giving beta, that is bilateral internal mammary artery, you are giving a better survival at the end of 10 years or 15 years. Initial 5 to 10 years, there is no difference, but yes, after 10 years, there is significant difference. But this was an observational study. There was no randomized controlled trial, and that is where the ARTS trial came in, and it showed at the end of 10 years, it was a randomized controlled trial, which shows that at the end of 5 years or at the end of 10 years, there is no major difference whether the patient is getting bilateral mammary artery or single internal mammary artery. Again, this was a big controversy, but yes, this is the fact, and this is considered as the landmark paper in cardiac surgery for bilateral mammary arteries. So there is no difference in composite endpoints of myocardial infarction or stroke. What was the only thing was seen is with the bilateral mammary artery, mediastinitis and wound infection was slightly higher. And whenever you are giving a bilateral internal mammary artery, certain things to be kept in mind is that patients with obesity, diabetes mellitus, COPD, old age, severe LV dysfunction should not get bilateral internal mammary arteries, and there are other technical issues that I am not going to discuss. So now let us come to another aspect, whether to use radial artery or right internal mammary artery or a venous graft. How to decide that? So there are 9 randomized controlled trials which are comparing radial artery with SVG, and 2 randomized controlled trial which are comparing RITA with RIMA with saphenous vein graft. And what are the data? If you see, only one study suggests that there is benefit by giving venous graft. But if you see the maximum advantage of radial artery, there are almost 5 to 6 studies which have shown that by giving radial artery, you are giving an advantage to the patient. Similarly, when you compare with radial artery and RIMA, that is right internal mammary artery, there are 2 data which suggest that radial artery is better than right internal mammary artery, and there is no randomized controlled trial which suggests that bilateral or RIMA, right internal mammary artery, is better than the radial artery. And this is the recent paper just published in 2022, which shows that the patency rate of radial artery is equal to internal mammary artery, and it is better than the SVG or venous graft. And what is the comparative patency rate if you compare it? Lima is 96% at the end of 10 years. RIMA is more than 100% at the end of 10 years, but the number of patients are less. Radial artery conduit almost 90%. Free RIMA, that is what we use it in Lima Y, the patency rate is 88%, and SVG has 82% at the end of 5 years. Again, lot of things depends on the target arteries. If the lesion is not very critical, then radial artery or mammary artery should not be used because they are dynamic arteries, they go into spasm. Lesion has to be more than 75 to 80% critical lesion then, and then arterial grafts do benefit. And based on all this data and research, the ACC AHA guidelines have come up and ACSA guidelines have come up, which says that to improve long-term cardiac outcome using a radial artery is recommended in preference to saphenous vein conduit, the second most important significant stenosed vessel, that is class 1 indication. Another class 1 indication is when bypass of LAD is indicated to improve survival and reduce recurrent ischemic event. Lima is preferably the left should be used to bypass LAD. Two-way recommendation is among the patients undergoing CABG grafting, bilateral or BEMA by experienced operators is beneficial in improving long-term cardiac outcomes. And what is very important is the class 3 indication. An arterial graft should not be used to bypass right coronary artery with less than critical stenosis, that is less than 90% of the stenosis. And use of radial artery may be reasonable when grafting left-sided coronary arteries with severe stenosis more than 70%. Special situations, diabetes mellitus, horrible vessels that you get, calcified and diffusely diseased arteries. You always prefer to go for bilateral memories or multi-arterial grafting. But the issue is bilateral memory. These patients will have a lot of comorbidities like obesity, diabetic nephropathy, advanced pulmonary disease, and elderly patients. So again, you should not go for bilateral memory artery with diffusely diseased arteries in diabetes mellitus. Similarly, now more and more elderly patients we are operating nowadays. And the purpose of doing a bypass surgery in an elderly patient is to prolong life, relieve distress, restore the function, and prevent long-term disability and dependency. So in that case scenario, yes, if you can give more arterial graft, it's better, but then you try not to achieve that should get bilateral memory or total arterial bypass grafting is not the aim in this category of patients. And renal failure patients, single ITA is desirable, but the risk of second ITA may not be justified. And requirement of radial artery for fistula is there, so always preserve radial artery in renal dysfunction patients. So at the end, the question is, one size fits all? No, it is never possible. Not all patients can get bilateral memory artery, not all patients can get total arterial bypasses. It is always the patient to patient you have to decide, and let the surgeon decide what is best for him and what is best for that. Unfortunately, what happens is, right now the patients come with a demand, I want to get this done and I want to get this done. But that is not the right way, because important thing is they should understand if that center is capable of doing all the things, then leave it on surgeon. They will decide what is the best for you. So one size does not fit all, needs to be understood by all. So in summary, large randomized controlled trials are there which has suggested that multi-arterial grafting is best. Second thing is bilateral memory artery as per the ARTS trial has not shown advantage at the end of 10 years, but yes, after 10 years probably, as the curves they diverge after 10 years, that is where the advantage may be seen. So the follow-up data of 15 years is still pending in ARTS trial. And superiority of graft, Lima and Rima is better than radial artery, is better than venous graft, is better than gastroepiploic graft. So this is the take-home message, and there is no one single bullet. You need everything in your armamentarium when you're treating a patient. So that is very important to understand at the end. Thank you very much, and I appreciate it.
So the topic for me at present, at this point of time, is challenge of calcium. I'll be talking about a technique, a technology which has taken over this world of interventional cardiology almost like a storm, I would say, over the past 3 years. Calcium has been a bane of interventional cardiologists for decades and for years to come. And it was one of the main reasons why interventions used to fail, or interventional cardiologists used to deny doing an angioplasty for patients, and they used to go to CABG by default. The moment you see calcium, you would simply send away to a surgeon to do it. But now then this technology came in, and there were alternatives, but they had their own problems, like say rotablation and all, wherein the learning curve was very steep. It had some problems, it had some it had complications, and there was an inhibition or an inertia on the side of interventionalists to try and avoid rotablation to a certain degree. And then, by default, all these cases used to go for bypass. But then this technology comes in, it simply acts as a disruptor, simply, disrupts the ongoing practice, and, just takes over. And, it was pretty much simple. It was just a slight extension of capability of an interventional cardiologist. It was so easy to master and so easy to perform, and with such good results, with so minimal side effects, that, it just took over. And, it has now come to, a point where it has become a mainstay of treating calcific coronary artery disease. So it is actually I would say it's a sound calcium strategy. So basically it is all about sound, and it is also sound in other ways. So it's a pun, and you could see that, it makes sense. So I have a a range of beautiful self-educational videos here, and I think they would explain, quite a few things as my talk goes on. What is the problem with calcium? Why it is a problem? So if you look at calcium, right, what it does is that, it impedes stent delivery. For an interventional cardiologist, ultimately what we want to do is open up an artery. But, you need to make your hardware reach to the block, right? But then with calcium, there is a problem with the deliverability. There is, even if you reach there, your stent cannot expand because the calcium would avoid doing it, right? And ultimately, if the stent doesn't expand, now that is the basic crux. If that doesn't expand, means the patient is going to come back in one way or the other. Either he comes back with thrombosis or he is going to come back with restenosis. And that is the problem. So how will you tackle this? And that is why the point here is that and more the calcium, the worse that these challenges will be. So these challenges are universal. More the calcium, more the problems. So there were outcomes, there were data, there were options. And what were these, options? Most commonly, high pressure balloons. So you go up with the balloon and inflate it at very high pressure, but then there is a risk. If you do that, you may perforate, isn't it? So therefore, these, would work at some point, but, may not at certain points of time and would have a problem there. Then, as I said, you have got rotational atherectomy, or we call it as rotablation. Now here you have got different sized burrs. Basically they are just drills which actually drill through the calcium. But again, the problem with, as I said, rotablation is that, you can only drill the superficial calcium. It cannot go deep into the artery. So it has to drill only the superficial part. Plus, it may not lead to a complete stent expansion. And the other thing is, as I said, it is a complex equipment which is difficult to master. So you require some experience in it, some expertise in it, and only then can you do rotablation. Otherwise, not every Tom, Dick and Harry can do it, So therefore, there is a limitation to use rotational atherectomy. And then comes this technology, which we call it as rotablation. So don't be surprised. It is one of those videos. I'm breaking the calcium.
IVL builds upon the principles of lithotripsy used for kidney stones, with adaptations made for safety, effectiveness, and ease of use to modify cardiovascular calcium. Far less energy is needed with IVL than traditional lithotripsy because the lithotripsy source is in close proximity to the calcium and the goal is only to fracture it, not pulverize. IVL modifies calcium through use of shock waves, which are a specific form of sonic pressure waves. The shock wave waveform has a rapid increase of peak pressure for approximately 1 microsecond, followed by a small negative pressure trough. To help minimize injury to soft tissue, IVL's waveform is designed to be different than traditional lithotripsy, which has a higher peak pressure and a larger negative pressure trough. To create an IVL shock wave, a series of emitters are arrayed within a balloon angioplasty catheter. The emitters fire electrical impulses across electrodes, which result in a plasma discharge, creating a vapor bubble that rapidly expands spherically, creating the initial shock wave. When the vapor bubble collapses, secondary smaller shock waves are created. The shock waves travel deeply and safely through soft arterial tissue because of the similar acoustic impedance of water and soft tissue. Fractures occur when the shock wave encounters tissue with differing impedances, such as the transition to superficial and deep calcium. The leading edge of the shock wave imparts compressive stress as it encounters calcium. Shearing occurs as it passes through the calcium. At the rear edge of the calcium, the shock wave is both transmitted and reflected, inducing tensile stress that pulls the calcium apart. Squeezing occurs when the shock waves entering the calcium travel faster than the remaining wave propagating outside the calcium. These forces result in multiplane and longitudinal fractures. IVL's intuitive platform and unique MOA, verified in both preclinical and clinical studies, consistently supports IVL's ability to modify superficial and deep calcium while being predictably safe, distinctively intuitive, and consistently effective.
So as you can see, it is a very simple technology. It has a balloon, and in this balloon there are emitters placed. So this lithotripsy is quite similar to the one which we are very well versed with our urology friends, isn't it? There you are breaking stones, here you are breaking calcium. So what it does is, it is just meant to fracture the calcium, and once it is fractured, then it becomes easier to expand your balloon to actually, compress the calcium, and then your balloon and your stent can expand. So it is not pulverizing. Unlike your rotablation and all, you are not pulverizing, so there is no calcium which is going into the bloodstream. So there is no slow flow and other complications which commonly happen happen with rotablation, but here unlike that, you are just cracking it, and with that you can expand, and ultimately you can have a very good result. So this is how the console looks like. This is the balloon catheter which goes inside. It is connected to a connector cable, and with this is the controller. With this we press and we can deliver the shocks, and with this the console you can see that there is a which sits outside, and with this you can actually see how many shocks you have delivered. So it is just an extension, like a small like your routine balloon that you use in your routine angioplasty. Right? And there are different applications now that are available for the shock wave, and which we commonly use in our day-to-day practice for peripheral arteries also, but the size would be bigger. So there are basically 80 pulses. So there are 8 cycles, and there are 8 cycles. There are 8 pulses, 8 cycles of 10 pulses. So total 80 pulses that you can deliver in one balloon. Right? Once. So whenever you plan your case, you have to plan it in such a way that the place where the calcium is the maximum, you deliver the maximum shock, and in the remaining segments you can deliver the rest of the shocks, because after that this balloon becomes useless, right? It cannot be used. So you have to take over another balloon. The only problem is it's an expensive technology at present. It roughly costs about 3,25,000 only for the balloon. So therefore your usage has to be very judicious, very, very justified, and only in cases where you feel that it is absolutely mandatory, that is where you should, at the present point of time, you should use it. So as you can see, it is almost like an explosion. So there is a sound wave, and in that there is a contrast and a saline solution, and there it actually produces an explosion. But you would ask me that does it not cause injury? No, but the energy that is produced is very, very little, and this energy is destined to hit only the calcium that hard. The soft tissue which is there beyond the calcium is not hit, because it is just dispersible. When it goes to the calcium, it comes back, hits it and comes back. So with the soft tissue, it will just dissipate through the soft tissue. So it doesn't injure the soft tissue at all. It just injures the calcium, and that is the beauty of this technology, right? So this is how it works. So it's a short burst of sonic waves, and with that, it is like this. So it is hard on hard. Just look at how it works. So in this video you can see that there is a structure which just looks like a calcium here. This is your hand. See, it is not injuring this guy. It is just a small shock like this. But if you look at here, you can see it is breaking the calcium, and this calcium just pulls apart. So this is the difference. This is the beauty of the technology, that it doesn't injure a non-calcific tissue, right? And that is why it is so safe. The other thing that you might ask me is, it is energy. So does it interfere with the heart rate? No. The amount of joule that is given is just 8 to 10 joules. And for this to produce an arrhythmia or a ventricular arrhythmia is unlikely, because for that you require a very high level of energy, much higher level, and that is why you don't see dangerous arrhythmias happening with IVL. So the procedure is very simple. You must it's a high profile balloon, so you create a space for that balloon by using a normal balloon first, semi-compliant balloon, create a space, then put in the IVL balloon, deliver the energy, right? Go to 4 atmospheres initially, where it is just opposing the vessel wall, then the shock will be delivered. Then once the shocks have been delivered, that is 10 pulses, then you can actually go up to 6. When you go to 6, the balloon just cracks open the calcium, creates some space, and then you can give another shock if desired. So this is how the technology works, and the beauty of this is that it can break both superficial, both deep calcium, concentric calcium.
Depending how calcium presents, the number of IVL pulses to achieve an optimal result are different. When the IVL balloon expands in eccentric calcium, the emitter moves away from the calcium, since the soft tissue is not constrained. The farther the emitter is from the calcium, the less energy is able to reach it, so more pulses are needed. While each pulse's energy is identical, shock waves crack concentric lesions quicker due to the rigid ring of calcium that traps the energy, leaving no other paths to dissipate other than cracking. Waves also reflect off calcium and impact the calcium in the opposite wall. In eccentric lesions, most of the waves pass through the soft intima, and there is negligible benefit of reflecting waves. Regardless of how much energy is required, the efficacy of the shock waves is evident under angiography.
So you could see that with eccentric as well as concentric, the IVL works very well. And there are a lot of data to suggest that IVL is pretty safe, and it is very, very effective. So I have a case to show you. We have done quite a few cases. In fact, I did one yesterday itself, very complex case. But this is one case which I would like to show it to you. Now this is an 82-year-old female, so you could clearly see that a high-risk individual, hypertensive, diabetic, morbidly obese, recently diagnosed with COX, started on AKT, ACS drop positive, acute LVF and ejection fraction of 35%. So as you could see, it's a very, very complex case scenario, and this is her RCA, right? So can you see this RCA here? This RCA has a critical block here. You could see here eccentric calcium. Can you see this? So there is a lot of chunk here, most likely a nodular calcium, and the disease starts right from here till here. So it's a long segment disease. Critically, there is a lot of calcium here, and these are the ones which, are most difficult to yield. So the issues here were access. One, because she was obese, getting a femoral or a radial access was difficult. There was a radial spasm already in this patient, very, very uncooperative, tortuous and a calcific RCA with critical and eccentric proximal lesion along with a long calcific segment. And again, in this case, we were having a lot of trouble with the guide support. So we start angioplasty, you could see we take our routine balloon. Just look at the balloon, it is not going below. This is our lesion and the balloon is not going. So what to do? So what we do is we take a small balloon, a 1.5 balloon. 2 balloon was not going, 2.0. We take a 1.5. Luckily, this balloon just goes in. Suppose if this hasn't gone there, then I would have to do a rota for this patient also. So it would become a rota plus an IVL. So it becomes something like a rotatripsy, right? But I take this 1.5 and luckily it goes in. And with that, I create some space for this 2 balloon to go. So 2 balloon goes in, I create some more space. And once I do that, I take in a guide liner here. This is a mother and child technique, our main guide catheter and a guide liner, because this helps to deliver the high profile IVL balloon. And with that, I can deliver the IVL balloon. Can you see this? So now the IVL balloon can go in. And once it goes in, then our job is quite easy, right? This balloon, IVL balloon, creates some space, and now I can deliver my stent. So you can see that the stent goes in pretty simply. So deliverability is simplified. I put in the stent, I inflate the stent. And then, because there is one more lesion, we take another stent. So you could see that the deliverability has improved, the stent has expanded, balloon has expanded. I can now post-dilate, and you could see the final result here. So this is the final result. Look at how good the result is. And this patient is doing well till now. So the take-home message is pretty simple, that IVL is an extremely safe, effective, user-friendly tool to deal with calcific lesions in various situations. Owing to the larger profile of the balloon, like in this case, guide liner becomes a very important adjuvant tool to facilitate the entry of the same. Be aware and prepared for backup steps in case the IVL can't cross the lesion or it ruptures. Very unlikely that it ruptures, but in case it does, then most of the times it does not create problem because it is at a very low pressure. But in that case, you have to be prepared because these are all complex cases. You are in any case prepared for any eventuality. But with IVL, the life has become so simple for interventional cardiologists, and we have started to adopt it for most of our patients of affordable patients who can afford for calcific coronary artery disease. So I hope that serves the purpose. Thank you one and all for your patient listening.
The reason for hot topic is this slide. You can see nowadays we are looking at a lot of deaths happening, especially in young to middle age, where we don't know what is the reason for death. There are a lot of multiple examples like students or celebrities, or there are a lot of general people also. They are dying at home, they are dying in the gym. Nobody knows the reason, and everybody are labeled as actually heart attack. But do we know that whether they are dying because of heart attack? No, they are dying because of cardiac arrest. They are not dying because of heart attack. So what is the difference? Do we know the reasons why they are dying? So we know that heart is a muscular structure which has 2 types of supply, like blood supply and an electrical supply. And whenever there is any issue with the electrical supply, that leads to the ventricular arrhythmias, VT or VF, and that VT or VF is the reason for sudden cardiac death or a sudden cardiac arrest. It is not heart attack. Heart attack may be the reason for VTVF and sudden cardiac arrest, but all sudden cardiac arrests are not heart attack. So what is SCD? SCD is one of the most challenging presentation of CV disease, accounts for millions of deaths. We know that out of hospital cardiac arrest prognosis is very poor. Less than 10% people will survive if they have a cardiac arrest outside the hospital. And the problem is that it is very sudden and rapid and gives a very limited opportunity to intervene or to do something to make that person survive. And that's why we need strategies to focus on trying to identify them well ahead of the sudden cardiac death event. That is the most important part. Like, what is the relative or absolute number of SCDs? This slide suggests that, the topmost is the MI, then EF less than 30%, then prior MI, known CD, and the last one is the general population, where we can see that general population is having the lowest incidence of death. It is just a 2% or something. But we can see the absolute number is huge. So according to this slide, huge number of people, absolute number of people are dying because of sudden cardiac death. They are actually from general population. They are not a diagnosed case of MI or LV dysfunction. So we need to identify those people who are moving around as a general person, does not have any problem, but they are at the having highest chance of getting, highest number, absolute number to get a sudden cardiac death. So this is a very important slide, like warning symptoms prior to sudden cardiac death. That is the opportunity for timely action. So we should know that sudden cardiac death is often not so sudden, and they are actually preceded by some symptoms in at least half of the patients. And that symptom may be chest pain, that may be dyspnea, it may be palpitation or syncope. We should not miss these symptoms at all. And we usually say that these symptoms recurrence is happening in 90% of the patient on the day of sudden cardiac death. So sudden cardiac death is not always sudden, and they can have some symptoms in the last 24 hours. So early diagnosis and prompt medical attention is the most important part to improve the survival in these patients. Now, there are a lot of newer technologies. Dr. Milind Desai already discussed all these things in the morning. Like there is a lot of new developments are happening, especially in form of artificial intelligence and the electrophysiology monitors to monitor the heart rhythm in different ways. There are a lot of different ways to identify. There are loop recorders, there are Holter, there are mobile phones. There are a lot of other methodologies are there to identify the rhythm or to monitor the rhythm when the patient is away from the hospital. So these all should be utilized meticulously whenever it is indicated. So we should use this commonly. So what are all the potential causes of cardiac arrest? We know that ischemic heart disease is a potential cause of cardiac arrest, but we can see there is a long list of non-ischemic cardiac disease which are equally important for as a cause of cardiac death, because when there are few studies where they have shown that, especially sudden cardiac death in young, we can see that ischemic heart disease represents 33%, but there are other 66% of sudden cardiac death who are not dying because of ischemic heart disease. They all are non-ischemic. They may be structural, or it may be actually pure electrical disease because of the arrhythmias. So we'll see the case 1. So case 1 is a 25 male who is having a palpitation and syncope. He has a family history of sudden cardiac death. His elder brother has died at 33 years of age. ECG and echo I will show in the next slide, but his angiography is normal. We can see the ECG. ECG is showing pathological Q waves. There are significant repolarization abnormality. So this ECG suggestive of some cardiomyopathy or something. Something wrong is going on. When we did the echo was showing significant hypertrophy of the septum, and basically by echo and ECG, this is a hypertrophic cardiomyopathy. Now, we should be knowing that what to do next to identify whether this patient is at risk of getting sudden cardiac death or not. How can we prevent it? And that is that's how we do for the risk stratification in this hypertrophic cardiomyopathy for the sudden cardiac death especially. So we do multiple, there is multiple methodology by doing risk stratification. We discussed yesterday. I have limitation of time today. So I'm not going into detail of it, but we did a cardiac MRI for this patient, and cardiac MRI was showing a significant transmural scar into the septum. There was mid-myocardial scar. The scar burden was almost 20% of total LV mass. So that suggests that this patient is having a significant myocardial scar. He is at a very high risk of getting sudden cardiac death because of VT or VF. What else we can do for this patient? So what we did a Holter for this patient, and Holter was showing that there were short runs of, So I have only 2 minutes. There are few NSVT. So this is one of the most important topic and getting shortest time. So I will be finishing it in 2 minutes. So Holter was showing runs of NSVT. This patient definitely at the risk of sudden cardiac death. Then case 2, paroxysmal palpitation. ECG was showing a sinus rhythm with pre-excitation. It's a WPW. And we always think that WPW patient, they are all safe patients, they will not die. There is no risk of mortality at all, but it is incorrect. There is a possibility of sudden cardiac death also in WPW syndrome, especially when they develop atrial fibrillation. So atrial fibrillation will become a pre-excited AF, and that is the reason that this patient should always get a EP study and to remove that bypass tech to save him from sudden cardiac death permanently. And the last case is case 3, a 70-year male, syncope, angiography was normal, and his Holter was done, that was also normal. So there was nothing in there. But ECG was showing left bundle branch block. Now I know that this patient is having a typical history of syncope which looks like an arrhythmia. So what to do? What next I can do to identify whether he is at risk of getting sudden cardiac death? So I can go for an EP study in this patient. So what I did an EP study to identify the HV interval, and HV interval was 90 millisecond, which is normally 35 to 55. So this patient is having HV interval almost double of the normal. So HV interval means
time taken from the his to the ventricle for the electrical wavefront to reach. So this patient was having a prolonged HV. He's at a very high risk of getting AV block. So we advised this patient pacemaker, but he was not ready to have pacemaker. He want to go home. So what I did, I will not send him home directly without anything, but I will attach at least one loop recorder so that we can document if anything is happening. So this patient went home without putting pacemaker. Then he had a sudden cardiac arrest again at home on the next day itself. Luckily, we had a Holter attached. So what was Holter showing? Holter was showing, you can see that he is having a paroxysmal high-grade AV block. There are a lot of P waves which is not conducted down into the ventricle. So this patient was having actually all syncope because of this paroxysmal high-grade AV block. So that we can document. So that's how, if we could have put a pacemaker in this patient at this point of time when his HV interval was 90 millisecond in EP study, we could have avoided sudden cardiac death in this patient. This patient luckily could reach to the hospital, but there are a lot of patients which we may be missing. We may be dying, patient may be dying at home without device. So that's how this patient actually, finally we put a pacemaker to save him from bradycardia related sudden cardiac death. So, there are a lot of emerging paradigm for ambulatory monitoring. So there are a lot of monitoring devices coming up for early detection, and we should be using it meticulously to identify those patients who are at risk of arrhythmia death. So my conclusion is SCD is often not so sudden. They are actually preceded by symptoms in approximately 50% of the patients, and warning symptom prior to SCD is an opportunity for timely action. So we should systematically and we should need a prompt evaluation to make early diagnosis, and that can only dramatically improve survival, nothing else. And the newer technologies which can lead to early identification of people at risk of sudden cardiac death. Thank you.
I don't require the entire dais, I just require a few audience and a podium. Thank you so much. So what we're going to do, the topic for the day is leadership in medical practice the Chanakya way. We all talk about different types of health, physical health, mental health, and there are two more health which is becoming prominent. One is called intellectual health, and of course the fourth one, which is very important, spiritual health. I was surprised when I spoke about mental health in an international conference and they told me write a paper on it. उसके ऊपर एक पेपर प्रेजेंट किया था लंदन में. Of course the whole idea was that भारत में spirituality तो है ही, but between spirituality and the mind we have something called as buddhi. And if you study Indian shastras or scriptures, these two words come out very prominently. Mana buddhi. तो मन के ऊपर बहुत काम हो रहा है, देह के ऊपर बहुत काम हो रहा है, but अभी काम होना चाहिए बुद्धि पे, और छोटा सा contribution है उस field में. And I was being told that this particular group, when I say this particular group, all of you are highly intellectuals, you understand biology more than maths. But here is a combination of biology and maths. Biology you teach me, maths I will teach you. Because now very soon I will be taking you to the other side of medical practice, that is called leadership. So let me start with a small question. When you hear the word leader or the field leadership, what is the first impression that you have? फिर आपके मन में क्या विचार आता है? Okay, person who is? Okay, at the front is a leader, okay? The one who follows other people is a leader, okay? जो राह दिखाता है वो leader है, okay? जो सबको साथ में ले जाता है वो leader है. When I ask this question in colleges, leader बोलते हैं आपके मन में क्या आता है? तो first impression is politician. है ना, क्यों नहीं? They are also right, we are also right. But then I say, it is not just about a position or a field, it's also an attitude. It's also an attitude. And there are so many things about leadership that today, leadership has become a field of research and practice. In fact, many of you from different fields will know that, maybe 20, 25 years ago when you started the medical practice, many people may not know that heart can be a specialization, right? Cardiology or nephrology या ophthalmology. तो that's सिर्फ आंख, सिर्फ heart, सिर्फ कान, ENT specialist. So you know what happened? I remember this joke. Who is a specialist? Who knows more and more about less and less? So somebody went to an ENT specialist. बोलता सर कान दुख रहा है. बोलता कौन सा कान? Right ear. So sorry, I'm a specialist of the left ear. Then he went to ENT specialist of the right ear. Then he asked him, कहाँ पे दुख रहा है? तो अंदर दुख रहा है. So sorry, मैं बाहर का right ear का डॉक्टर हूँ. But I'll tell you, in India now you'll see this. You can be a specialist with generalist. That is a combination. इतना नीचे मत जाओ कि ऊपर का भूल जाओ, और इतना ऊपर मत जाओ कि नीचे का छूट जाए. So इसके लिए एक I'll start with a small शास्त्र का उदाहरण. The way you look at things. So we are going to now slowly look at training the intellect. The way you look at things should have two drishti. One is called Sarpa drishti and the other is called Garuda drishti. You know who is Garud? Eagle. ऊपर का सब दिखता है. He is not concerned about micromanagement. You know who is a Sarpa? सिर्फ नीचे का ही दिखता है. And a Sarpa or a snake can only see from this distance, isn't it? So this one is called bird's eye view. And this one is called detailing. Leaders should have a combination of both. We should be here, but if required, we can come down also. Isn't it true? को ऊपर इतना लटके रहते कि नीचे का कुछ समझ में नहीं आता है. बहुत सारे अपने घरों में या इंस्टीट्यूशन में या हॉस्पिटल्स में क्लिनिक में चोरियां हो रही है. मुझे नहीं पता कौन की है. अरे that's not my area. और कोई लोग इतना नीचे का देखते कि ऊपर का कुछ सोचते नहीं है. नो विजन. So combination of macro and micro is leadership. Combination of macro and micro is leadership. So with that, this Radhakrishnan Pillai, Dr. Radhakrishnan Pillai will speak to all of you who are doctors of medical field to bring out a combination in the field of leadership. I've been already briefed by everyone over here, the organizing team, that many of you may be working in hospitals, many of you are entrepreneurs, some of you may have clinics, some of you may have hospitals, isn't it? Let me start by telling that irrespective of that, this will be useful for everyone. Even if you are a single person clinic, this will also help you. If you have a multi-specialty hospital also, it will help you. So that is the way Chanakya would help us. So with that, what I'm going to do, I'm going to just go through two parts of my presentation. The Chanakya, the person, and how do we apply it in today's field. I've written 21 books on Chanakya. And you know, the topics are only interesting. Many people ask me, "Itna kaise likhte ho? To kya karega?" You know, once you start developing love, you want to know more and more. So the most famous is Corporate Chanakya. And for those interested, the one on the right side is interesting book, Chanakya and the Art of Getting Rich. So there are books for children also, Chatur Chanakya. But what is interesting is not the books. A book can take you to many places. So I hope all of you will write books in your lifetime. How many people have written books over here? I met sir also, I was so impressed. Sabko likhna hai, because the younger generation will catch you up. I was so impressed by the organizing team that we have paper presentations, isn't it? Poster presentations. Publishing has become a very common thing. If you don't know how to write a book, come to me. I have written a book on that also. I'll tell you, you know, since we are in Gujarat, आंकड़ों में बात करो. Do you want to write a book or do you want to write a best-selling book? Do you want to write a book or do you want to make that book a bestseller also? And let me tell you, all my 21 books are bestsellers. All. But let's be practical. Many people ask me, what is the meaning of a bestseller? And you know what I tell them? 10,000. Or India mein 10,000. So actually it's not difficult. I speak to a lot of CAs, IAS officers, IPS officers. And you know, when you look at all this, are tune CA crack kiya? You have cracked civil service exam. You know what the people say? You only worry about those people who did not crack. But there are a lot of people who did crack. So I think all of you should write a book, because each of your story actually is a story and experience for somebody else. So let me start with one small story, and I'll tell you how it will help in the medical field in leadership. And it's the actually story of a doctor from Bombay. And you know, he came for one of my book launches, and he came to me and said, you know, sir, I would also like to write a book. बोले कि आपके अनुभव बताओ. He was a Guinness Book of World Record holder in surgery. He had removed a big tumor and all those things during his time. तो इतनी बड़ी कहानी है, इतने बड़े हो आप, क्यों नहीं लिखते? तो बोला आता नहीं है. कोई बात नहीं, अनुभव है ना, लिखेंगे. After 2 years, once he called me and saying that book ready है. अच्छा, very good. आपको आना है किसके लिए? Book launch. ठीक है, गया मैं book launch में, and then it was covered in the media and all those things. Very famous doctor, and it was covered in the media, television, this and all those things. My wife was not present for that book launch, but after 1 week, she actually told me, she calls me Radha. Okay, राधा आज का पेपर पढ़ा क्या हो गया? वो तुम्हारे डॉक्टर चले गए. तो कौन से डॉक्टर चले गए? सबको जाना है. द सेम डॉक्टर जिसने तुम्हें उस दिन बुक लॉन्च पे बुलाया था. मतलब डोंट टेल मी, रियली आई रेड दैट एंड ही हैड पास्ड अवे. द स्टोरी डजंट एंड हियर, द स्टोरी बिगिंस हियर. ओके, सो ये तो चले गए, बुक रिलीज हो गया, चलो. आफ्टर अराउंड अ ईयर, आई रिमेंबर आई वाज इन बैंगलोर. Anybody from Bangalore here? I know not many people are here. But if you go to Bangalore, there is a chain of bookstores called as Sapna bookstores. Suna hai aapne? Please go there. It's very interesting. Sapna bookstores I have found is the only bookstores in India which has got a separate section for medical textbooks. Bangalore में शायद culture होगा पता नहीं. In Chennai, if you go to supermarket, there is a section on musical instruments. वहां पे साउथ में सबके घर पे कुछ ना कुछ चलता है ना, गाना बजाना. तो बैंगलोर आई वाज इंटरेस्टेड. तो हम ऑथर है तो हम जाके देखते हैं कि कहाँ पे कौन सा किताब है. एंड आई वाज सरप्राइज्ड दैट बुक व्हिच ही रोट एंड व्हिच गॉट रिलीज्ड वाज ऑन द बेस्ट सेलर लिस्ट नंबर 1. तो मैंने वो ऑनर से जाके पूछा कि साहब ये क्या है, ये बुक के बारे में कुछ बताओ. तो बोलता ये यहाँ के सारे मेडिकल कॉलेजेस में दिस इज द रेफरेंस टेक्स्ट बुक गिवन बाय ऑल द प्रोफेसर्स. व्यक्ति चले गए लेकिन ज्ञान रह गया. I want to tell this, that is not about Radhakrishnan Pillai's story, it is your story that begins from today. Do you believe you are successful? Yes or no? अब यहाँ पे हो तो successful हो भैया. But the problem is that we don't know how to carry on our success to the next generation. And the best thing to do is start by writing a book. In fact, I keep doing a lot of workshops also. I will invite all of you. But now see what a book can make you reach. How many of you know he is an author? Not Radhakrishnan Pillai. The one on the other side is also an author. Are you aware of it? He's written a book called Exam Warriors. He's written his own biography also, Mondiji. And the first time he actually called me when he was the CM of Gujarat. And he said, "Tumhare Chanakya batao kya karna hai." So it is not about book, it's about giving your knowledge to others. So I request that at the end of this particular tiring day, at the end of all this thing, you take back one thought. Maybe किताब लिखूंगा या लिखूंगी. ये मत पूछना कौन पढ़ेगा. आपके जाने के बाद बहुत जन पढ़ेंगे. शायद चाणक्य के जाने के बाद मैं पढ़ रहा हूँ. Okay, so with that we'll do the first part of our presentation. Go back to history. चाणक्य के बारे में सुना है सबने? So who was he? When did he live? What did he do? And why is he a legend? कि आज इतने सालों के बाद भी हम चाणक्य के बारे में बात करते हैं. Anybody remembers who was चाणक्य? कौन थे? Any story? Anything connected? Who was he? What did he do? Advisor. चंद्रगुप्त मौर्य. ऐसा बोलते हैं ना गूगल में कीवर्ड्स. प्रधानमंत्री, एडवाइजर, किंग मेकर, चंद्रगुप्त मौर्य और क्या? अर्थशास्त्र, टीचर, फिलोसोफर, स्ट्रेटेजिस्ट, author, everything. So jurist. And one word which I like the most about Chanakya is called polymath. Have you heard about this word? A person who can be a specialist in multi-disciplines. हमको तो अभी वही बोल रहे हैं ना कि स्पेशलाइजेशन, नथिंग रॉन्ग इन दैट, बट एक व्यक्ति को बहुत कुछ आता है, देखेंगे हम. And the important thing is that he is a person who is called a mastermind of that generation which became the richest part of the world. भारत को कहते हैं ना सोने की चिड़िया. We were the richest part of the world, सुना होगा आपने. बट किसने किया? उसका निर्माण करने वाले चाणक्य. Spiritually and materially also. Do you want to have both? How many of you want to make money? Indians में है, बोलते नहीं है. So he will teach you how actually you can make ethical money. Dharma और artha, interesting combination है. So a lot of things Today I will not be able to cover the whole life of Chanakya, but I'll give you some small indication so that your interest in Chanakya grows after I leave. So born in the 4th century BC, known by 3 names, Vishnugupta, Kautilya and Chanakya. History tells us, ये इतिहास की कहानियां हैं. He had taken down the Nanda dynasty. सुना होगा ना आपने, नंदा राजा थे. If you want to know more the strategy की कैसे एक साधारण शिक्षक ने एक बड़े शासक को नीचे उतारा. There is a serial called Chanakya by Dr. Chandraprakash Dwivedi. Doctor is a medical doctor who became an actor and director. Interestingly, it's based on a Sanskrit book called as Mudra Rakshasa by Vishaka Datta. Please study that or at least see that particular serial. It's available on YouTube, 47 episodes free of cost. Indians like the word free. So how he pulled down Nanda, that is the second story, but what is interesting is Chandragupta Maurya, uske kingmaker. Okay, anybody who actually heads hospitals here, big institutions, we have a few people over here. Okay. Believe me, the biggest challenge for a person who is having leadership role is mere baat kaun chalayega. True or no? It's called succession planning. एक राजा को निकाल दो, नंदा राजा को, लेकिन चलाएगा कौन? It's a very important leadership problem. लीडर का सबसे बड़ा प्रॉब्लम ये नहीं होता कि मैं लीडर कैसे बनूं. That is फर्स्ट चैलेंज. सेकंड इज मेरे बात क्या है कि नहीं. और भारत में तो हम हमारे बच्चों के साथ इतना अटैच रहते हैं, बच्चे हमारे साथ अटैच नहीं है. बट होते हैं ना, वो लायक है क्या. सो इट्स अ वेरी इंटरेस्टिंग चैलेंज. चाणक्य ने सब कुछ सोच के लिखा है. एनीवे दैट्स नॉट द पॉइंट. चंद्रगुप्त मौर्य को उन्होंने सेलेक्ट किया, ट्रेन किया और एक राजा बनाया. एंड बाय द वे आई डिड नॉट नो टिल लास्ट वीक द चंद्रगुप्त मौर्य का जो साम्राज्य था, आजकल ग्लोबलाइजेशन की बात कर रहे हैं, राइट. इट वाज देयर इन बॉम्बे ऑल्सो. बॉम्बे, द फाइनेंशियल कैपिटल ऑफ टुडे, वाज अंडर चंद्रगुप्त मौर्य's लीडरशिप. एंड यू विल बी सरप्राइज्ड दैट पाटलिपुत्र, पटना, मॉडर्न डे पटना, हैड इट्स किंगडम एक्सपेंडेड ग्लोबली. और ये देखो, अलेक्जेंडर आए थे, सब लोग आते हैं इंडिया में लूटने के लिए, राइट. अलेक्जेंडर भी आए थे, लेकिन चाणक्य ने उनको पराजित किया. कैसे किया, दैट्स अनदर स्टोरी. बट अशोका, द ग्रैंडसन ऑफ चंद्रगुप्त मौर्य, बिकेम ए ग्लोबल एम्परर. आप देखते हो कि जापान में भी आज भी चाणक्य की क्लासेस होते हैं. You'll be surprised. Okay, do we have range in this particular hall? Mobile range? Okay, I would request, I don't like distraction, but I can give you permission for 2 minutes to do a small exercise. Ready? Okay. Anybody has heard which is the world's oldest running company? चलो कर लो गूगल, मैं नहीं आंसर करूंगा. टाइप वर्ल्ड्स ओल्डेस्ट सर्वाइविंग कंपनी, इवन टुडे इट इज देयर. और कितना साल पुराना वो देखिए. Quickly, I'd like to have 1 or 2 volunteers who can tell me if you have found it. World's oldest company. हाँ, Congo भूमि. हाँ, now that is the company's name. कितने साल पुराना है वो? कितने साल हो गए? More than 1500 years. कितने? 1500 साल. Can you have a company that has survived as family business for 1500 years? सुना है कभी ऐसे? इंडिया का ओल्डेस्ट कंपनी इज 300 years old. टाटा इज ओनली 150 years old. Can you believe that we have a company existing today in another part of the world which has survived 1500 years? आपने गूगल किया है. अच्छा, अभी आप बाद में गूगल करना, अभी रख दो बाजू में. वर्ल्ड के टॉप 10 ओल्डेस्ट कंपनीज, 8 out of 10 आर फ्रॉम जापान. बाकी तो यूरोप के हैं, इंडिया में अभी आया नहीं है. एंड यू विल बी सरप्राइज, ऑल ऑफ देम एक्चुअली अप्लाई चाणक्य नीति. यू नो, दुनिया भर में हमारा योगा जाता है. योगा हैज बिकम, आई थिंक ऑल ऑफ यू नो इट, राइट. तो योगा हो गया, आयुर्वेद हो गया, गायत्री मंत्र हो गया, सब ठीक है. नाउ वी आर कमिंग बैक टू चाणक्य. इट इज ऑल्सो इक्वली इंपॉर्टेंट दैट इंडियंस अंडरस्टैंड इट. Chanakya for leadership and Chanakya for institution building. So if you have a small clinic or a big hospital, can it survive for 1,000 years? 1,000 years? हमको अगले 25 साल का पता नहीं है, अगले 5 साल का पता नहीं है. No problem, we'll see how to do that. Okay, so Ashoka became India's first global emperor, and Ashoka is taught in every school in Japan even today. हम भूल गए, वो सिखा रहे हैं. ठीक है, कोई बात नहीं, कहीं तो सीखने दो. Have you heard about Vipassana? Vipassana was a Buddhism technique of meditation which came to India through Burma. पता है आपको ये बात? So Goenka ji, the modern day teacher of Vipassana, actually was in Burma. वहां पे उन्होंने एक बुद्धिस्ट मॉन्क वॉज नॉन इंडियन, उनसे सीखा और बाद में इंडिया में आके फैलाया. ठीक है, कोई बात नहीं. जिससे ढूंढा गली गली घर के पिछवाड़े मिली. तो सारे मैनेजमेंट लीडरशिप के दुनिया भर के लेसन्स हमारे यहाँ पे है. एंड आई एम गोइंग टू अप्रिशिएट. देखिए, हमारा भारतीयों का एक प्रॉब्लम है, वी अप्रिशिएट अ लॉट. हमारे जमाने में ऐसा था वैसा था, कुछ नहीं. Let us come back from the past to apply in the present for a glorious future. I will repeat it. Let us come back from the past to understand the application in the present for building the future. That's leadership. Okay. Of course, he documented all these things in Kautilya Arthashastra and Chanakya Niti. ठीक है, तो ये मेरी कल्पना नहीं है, इट्स डॉक्यूमेंटेड. हो सकता है कल आप जो किताब लिखे उसके ऊपर कोई और रिसर्च करे. Do you want somebody to do research on your life? मैं तो छोटा आदमी हूं, मेरे ऊपर कौन रिसर्च करेगा? By the way, all of you are supposed to be doctors and researchers. Isn't it true? And you have no idea what one line of your experience can do a breakthrough of research in somebody else's generation. एक छोटा academic उदाहरण दूंगा. As a friend of mine, I am from University of Mumbai. I guide lot of PhD students, सिखाता हूँ leadership, ये सब करते हैं. So her name is Dr. Madhavi Narsale. She is the head of Sanskrit department in Mumbai University. एक बार हम ऐसे बात कर रहे थे और उनका विषय, और मैंने पूछा तूने PhD कैसे किया and all those things, and she told me something very interesting. And I want to share with all of you to inspire you that never take your experience for granted. Never take your own experience for granted. So she told me something very interesting. So when I was doing my PhD, my guide told me कुछ अलग करना, अलग मत सोचो, अलग सोच के कुछ अलग करो. तो कैसे कर रहे हैं? How to do breakthrough while doing a PhD research. संस्कृत उनका क्षेत्र है, हर फील्ड में संस्कृत. Go and search the library. Go and search the. In Bombay, there is Mumbai University has got a very monumental structure called as Rajabai Tower. देखा है आपने? It's an iconic structure. World Heritage structure में आता है, next to BSC, Bombay Stock Exchange. Okay, and that building is full of books. More than 8 lakh books are there. When Obama came to India as a president of America, he actually came to Bombay University before going to Delhi. That's why America is better than India in research. Isn't it true? They believe in book and reading culture. So Madhavi went to that particular library, 2 दिन बैठ के books पढ़ रही थी, and she found a book, very interesting book of Sanskrit grammar. उन्होंने निकाला वो book, and you know book के पीछे library में होता है ना issued, कौन से date पे issue किया, देखा एक बार भी issue नहीं हुआ. She went to the librarian और देखा the book was published 100 years ago. Not a single person has read it. Book was published 100 years ago. Book वो library में पढ़ा रहा. 100 साल के बाद ये माधवी उधर जाती है, बोलते ये बुक मुझे चाहिए रिसर्च के लिए. एंड द लाइब्रेरियन सेज तुम पहली पर्सन हो जो 100 साल में इस बुक को ले रहा है. एंड शी डिड अ PhD ऑन दैट पर्टिकुलर बुक एंड शी गॉट अ गोल्ड मेडल. व्हाई एम आई टेलिंग यू दिस फ्रेंड्स? आप अपने आप को छोटा मत समझो. आप जो मैं देखता हूं ना चाय पीने के टाइम में एक दूसरे का अनुभव बात कर रहे हैं आप लोग. आई डोंट अंडरस्टैंड टेक्निकल थिंग्स, बट व्हेन यू आर शेयरिंग योर नॉलेज, you have no clue how important your knowledge is for the next generation. तो चाणक्य ने पूरा अपनी जो नॉलेज है, लर्निंग सीरीज है, छोड़ के गए. व्यक्ति चला गया, ज्ञान रह गया. व्यक्ति चला गया, ज्ञान रह गया आने वाली पीढ़ियों के लिए. So with that, I would like to start on leadership, but before that, I'll show you a small video on Chanakya, and I'm very clear on one thing, that leaders who don't have understanding of finance can never be leaders. Leaders who don't have understanding of finance cannot be leaders. That doesn't mean you have to be commercially minded. But if you don't understand about financial matters, you'll never be a leader. And here I'll also be sharing some ideas about leadership and entrepreneurship. Entrepreneurship, आजकल इंडिया में चला ना स्टार्टअप इंडिया, लेकिन स्टार्टअप के लिए लीडरशिप क्वालिटी लगती है. So what I will do is I will play a small video. It is from a serial called as उपनिषद गंगा. देखा है आपने? देख सकते हैं आप YouTube में. So I'll play a small video. It's in Hindi. बहुत सारे संस्कृत टर्म्स है, बट इंग्लिश के सबटाइटल्स भी है. So requesting to play that small video. 5 मिनट का वीडियो है, फिर हम लीडरशिप पे जाएंगे. या
प्रणाम आचार्य. सम्राट, क्या मगध विजय के पहले तुम्हारी सेना नंदीग्राम के पास ठहरी थी?
हाँ आचार्य.
क्या तुम्हारी सेना ने ग्रामवासियों से अन्न लिया था?
हाँ आचार्य.
क्या उसका मूल्य चुकाया गया?
शायद नहीं.
हाँ या नहीं?
नहीं आचार्य.
क्या समझकर तुमने वो अन्न ग्रहण किया? दान या दक्षिणा?
मैं समझा नहीं आचार्य.
शारंगराव, सम्राट को दान और दक्षिणा का अर्थ समझाओ.
सम्राट, दान वह मूल्य है जो सामाजिक कर्तव्य के रूप में दिया जाता है, और दक्षिणा वह मूल्य है जो किसी सेवा के बदले में दी जाती है.
तुमने क्या लिया? दान या दक्षिणा?
क्षमा आचार्य, मैं उस अन्न का मूल्य चुका दूंगा.
ध्यान रहे चंद्रगुप्त, हर वस्तु का मूल्य है, हर सेवा का मूल्य है, और जिसका भी मूल्य है वो अर्थ है, और धर्म और काम अर्थ पर ही निर्भर है. इसलिए अर्थ व्यवहार धर्मपूर्वक हो. बिना मूल्य दिए दूसरे का द्रव्य लेना दूसरे के द्रव्य का अपहरण है, और दूसरे के द्रव्य का अपहरण अपने द्रव्य का नाश है. सम्राट, अन्न और प्रजा ही तुम्हारा धन है, और अन्न का प्रजा से संबंध है. बात समझ में आई?
हाँ आचार्य.
अब तुम जा सकते हो.
यही बात आचार्य मुझसे एकांत में भी कह सकते थे, पर नहीं, मुझे अपमानित करने में उन्हें आनंद आता है.
सम्राट, आप आचार्य को गलत समझ रहे हैं. ये तो उनका आपके प्रति स्नेह है.
थक गया हूं स्नेह के इस बंधन से मैं.
सम्राट की जय हो. समाहर्ता आपसे तुरंत मिलना चाहते हैं.
अब इस समय समाहर्ता को क्या काम आ पड़ा? भीतर भेज दो उन्हें.
मगध सम्राट की जय हो. सम्राट, बात ही कुछ ऐसी है कि मुझे इस समय यहां आना पड़ा.
कहो.
सम्राट, श्रेष्ठी सुदत्त और दूसरे कई श्रेष्ठियों को न्यायालय के आदेश पर चुंगी घर के सामने धूप में खड़ा कर दिया गया है.
उनका अपराध क्या है?
कर चुराने की कोशिश.
समाज के प्रतिष्ठित व्यक्तियों को समाज के सामने लज्जित किया जा रहा है, और मुझे इस बात की सूचना तक नहीं. क्या आचार्य को इसकी सूचना है?
आचार्य विष्णुगुप्त के आदेश पर ही उन्हें यह दंड दिया गया है.
मैं आचार्य से मिलना चाहता हूं इसी समय.
जो आज्ञा सम्राट.
आयुष्मान भव. कहो, कुछ कहना चाहते हो या कुछ पूछना चाहते हो?
आचार्य, प्रथम आसन तो ग्रहण करें.
शिष्टाचार में समय गंवाने का मेरे पास समय नहीं है सम्राट. जो पूछना है सीधे पूछो.
आचार्य के पास मेरे लिए समय नहीं है.
आचार्य के पास जो समाज को धन देते हैं उनके लिए भी समय नहीं है। मेरी समझ में नहीं आ रहा है कि आचार्य किसकी चिंता में व्यस्त हैं।
समाज की। मेरे लिए व्यक्ति नहीं, देश महान है। मेरी निष्ठा न चंद्रगुप्त में है न चंद्रगुप्त के साम्राज्य में। मेरी निष्ठा समाज के उत्कर्ष में है। मैं उसी के बारे में सोचता हूं चंद्रगुप्त। इसीलिए मैं कर का चिंतन करता हूं। इसीलिए मैं दान का चिंतन करता हूं। स्मरण रहे चंद्रगुप्त, समुद्र से जल भाप बनकर बादल बन जाता है, फिर वही बादल वर्षा की बूंदें बनकर जल जल में मिल नदियां बन सागर बन जाता है। वही जल अर्थ है, कर वही अर्थ है जो राज्य का आधार है, और दान वही अर्थ है जो समाज का आधार है। ये समाज ही सागर है। यदि सागर का जल सागर में न मिले तो अर्थ अनर्थ है। इसीलिए राजा कर लेता है और समाज दान देता है। जिस मगध में प्रतिष्ठित श्रेष्ठी कर नहीं चुकाते, ऐसे मगध में एक ऐसा अपरिग्रही ब्राह्मण भी रहता है जो भिक्षा में मिले अन्न को भी सूर्यास्त से पहले बांट देता है ताकि वो किसी की भूख मिटा सके। बताओ चंद्रगुप्त, मैं किसका सम्मान करूं? कम से कम में जीने वाले उस आचार्य का, या कर न चुकाने वाले उन प्रतिष्ठित श्रेष्ठियों का?
I have already given the PPT. मैं छोटा सा रिक्वेस्ट करूंगा कि आप लोग इस वीडियो को बार बार देखें, क्योंकि एक बार देखने से समझ में नहीं आएगा. There are many words which is there in this दान, दक्षिणा, करा, मूल्य. It looks like financial terms, but in India we have looked this as philosophical terms. ये केवल कोई फाइनेंशियल टर्म नहीं है, जार्गन नहीं है, इसके पीछे बहुत अध्यात्म छुपा हुआ है. चलो एक प्रश्न आपको से पूछता हूं, उससे आपको थोड़ा सा समझ में आएगा. इज देयर डिफरेंस बिटवीन दान एंड दक्षिणा? हमें नहीं समझ में आता, वी मिक्स अप. तो लेट मी पुट इट दिस वे. आप डोनेशन करते हो, उसको क्या कहते हैं? दान. अगर कोई आपके सर्विसेज लेता है एज ए मेडिकल प्रैक्टिशनर, इफ दे पे यू सम फीस, दैट इज कॉल्ड Dakshina. And if you don't give Dakshina, that knowledge is not complete. Isn't it true? और यहाँ पे we are expecting कि ना लोग हमसे फ्री में लेके जाए. नहीं, आपको फ्री में देना है, बट उनको पे करके जाना है. गुड और बैड? आपको फ्री में देना है बिकॉज दैट्स योर दान टू द सोसाइटी, लेकिन उनको पैसे नहीं देना है, वो गलत है. Isn't it true? जिस दिन दान और दक्षिणा एक साथ आ जाएगी, विल बिकम द रिचेस्ट कंट्री इन द वर्ल्ड. ना वो देते हैं ना हम लेते हैं. आपको लेना चाहिए, मिल गया तो. मैं आपको एक छोटा उदाहरण देता हूं. हम लोग एक ग्रुप ऑफ ज्योतिष को ट्रेन कर रहे थे. आई एम वेरी फॉर्चुनेट. चाणक्य के साथ किधर किधर गया हूं. वी ट्रेन द आर्मी. लास्ट वीक आई वाज इन दिल्ली ट्रेनिंग इनकम टैक्स ऑफिसर्स, और यहाँ पे डॉक्टर्स. सो यू नो ज्योतिष लोगों के यहाँ पे एक ये चलता है, आई वुड से एक परंपरा. आई डोंट नो इफ यू नो अबाउट इट. आपके सबके फैमिली ज्योतिष होंगे ना. They're not supposed to take money, but they're supposed to accept money. फर्क है इसमें. They're not supposed to take money, but they're supposed to accept money. फर्क क्या आपको बताता हूँ. तो ज्योतिष का गए, उनका जो भी प्रश्न है सब हो गया, कुंडली वगैरह देखी, पूजा वूजा का जो भी है. फिर इस बंदे ने पूछा, सर कितना लोगे? अनफॉर्चुनेटली फीस इज नॉट दक्षिणा. करेक्ट? तो ज्योतिष जी ने क्या बोला? यथाशक्ति यथा भक्ति, एज पर योर बजट. तो उसने निकाला जेब से जो भी रहेगा, 500-1000 रुपया जो भी होगा, एंड ही डिड नॉट एक्सेप्ट इट. गुड और बैड? बैड. देखो ये बहुत बड़ा फिलोसॉफिकल डिस्कशन. आप सोचना इसमें. ऑल योर फाइनेंशियल प्रॉब्लम्स विल बी सॉल्व्ड इन दिस कंट्री. उसने बोला मैं ले नहीं सकता, तो मुझे देना है. एग्जैक्टली. बहुत आपको देना है, मुझे लेना नहीं है. तो क्या करें? उसने वहां पे अपने गुरु का फोटो लगाया था. बोला यथाशक्ति यथा भक्ति वहां पे डाल दो. then he put that money. और शाम को जितना भी कलेक्ट होता है, his wife takes care of that. We don't understand this model. इसके पीछे बहुत बड़ा रहस्य है. I will give my services to the society, and the society has to take care of the services of that person providing the service, isn't it? ना हम लेना जानते हैं ना वो देना जानते हैं. फिर अमेरिकन मॉडल आ जाएगा. And we think we are modern. Anyway, इसके ऊपर कोई philosophy का discussion बाद में करेंगे. Today we'll stick to leadership, ठीक है? But why am I telling you is that the government also has to take taxes, isn't it? But हमारे यहाँ पे क्या होता है, taxes का मतलब how to evade tax और how to do tax planning. And I trained CAs also. भैया मेरे. Anyway, तो चाणक्य was an economist जिसने अपने देश की philosophy economic angle से इतनी बड़ी बनाई कि वे the richest part of the world. Anyway, we'll come back to modern India, which is not the richest part of the world. It's on the way to. That's why we require चाणक्य more. Anyway, तो ये सब हो गया. ये सब फोटो वोटो दिखा के हो गया. चलो ये भी हो गया. So we now look at one more slide before we go to the modern day application. देखिए अर्थशास्त्र ऐसी किताब है जिसमें बहुत सारे विषय चाणक्य ने एक ही किताब में लिख डाली. known as a book of economics, statecraft, राजनीति, punishments, दंड नीति. Leader should have a quality of punishment. आप करते हो punish? If you are a leader, punishment का मतलब ये नहीं मारना, but you have to be strict, isn't it? लेकिन that should not be out of power or revenge. It should be for disciplining, isn't it? In fact, हम हमेशा कहते हैं कि जिस घर पे punishment नहीं होगा, वो घर ठीक नहीं रहेगा. इसे कहते हैं मर्यादा. And somebody said it very nicely. For the healthy development of a child in every family, the love of a mother and the discipline of a father both are required. Isn't it true? The love of a mother and the discipline of the father. आजकल unfortunately mothers दोनों करते हैं. But you have to understand discipline keeps the society together. Isn't it true? You'll be surprised. America is very strict with its law. Huh? Very strict. हमारे यहाँ पे इंडियंस, मैं आपको एक इंटरेस्टिंग चीज शेयर करता हूँ. आई वाज ट्रेनिंग द इनकम टैक्स ऑफिसर्स ना, तो हम लोग बाद में लंच पे बहुत कुछ सीखने को मिलता है. तो दुनिया भर में जितने भी स्कैम्स होते हैं, सुनिए ध्यान से, दुनिया भर में जितने भी स्कैम्स होते हैं, देयर इज वन इंडियन इन्वॉल्व्ड. तो मैं भी हंसने लग गया था. ऐसा क्यों? बिकॉज इंडियंस नो हाउ टू थिंक डिफरेंटली, बट दे डोंट नो हाउ टू यूज इट पॉजिटिवली. तो यही out of the box thinking, if you can use it positively, you can reach God also, isn't it? So intelligence is used for something uncreative. Intelligence can be used for even moksha. And Bhagavad Gita में इसे एक word कहा गया बुद्धि योग. We only know about ज्ञान योग, कर्म योग and भक्ति योग, right? विवेकानंद जी ने उसके ऊपर बहुत लिखा है. But there is बुद्धि योग also, जो चाणक्य यूज करते हैं. Anyway, warfare. चाणक्य wrote on रणनीति. And of course नीति. We'll see some of the leadership नीति today. ये किताब आप पढ़िएगा, ये नहीं पढ़िएगा तो मेरी किताब पढ़िएगा. My book is based on this book, अर्थशास्त्र. About 6,000 सूत्रास. आप सोचिए 6,000 सूत्र उन्होंने गवर्नेंस के ऊपर, लीडरशिप के ऊपर लिखी है. Divided into 15 books, 150 chapters, 180 sections. आपको अगर नहीं पढ़ना है इतना, मुझे कहा गया है कि आप लोग बहुत पढ़ते हो. डॉक्टर बनने के लिए भी पढ़े और डॉक्टर बनने के बाद भी पढ़ते हैं. अच्छी बात है. बट मैं बोले 5 सब्जेक्ट शुड बी मास्टर्ड फॉर लीडरशिप. इट्स अ बुक ऑन लीडरशिप. और 5 चीज अगर आप पढ़ लो जो चाणक्य के अर्थशास्त्र में है, फंडामेंटल्स ऑफ लीडरशिप. आई होप यू विल स्टार्ट रीडिंग बुक्स ऑन लीडरशिप. मेडिकल फील्ड हो या कोई भी फील्ड हो, यू शुड स्टडी इकोनॉमिक्स. एंड इकोनॉमिक्स इज नॉट ए ड्राई सब्जेक्ट, इट्स अ वेरी इंटरेस्टिंग सब्जेक्ट. प्रैक्टिकल इकोनॉमिक्स बोलते हैं उसको. आई एम नॉट टॉकिंग अबाउट फाइनेंस. Finance is a very accounting subject. Economics is very different. If you develop that acumen, इसलिए मैं हमेशा कहता हूँ, don't become money minded, but be money conscious. Don't become money minded, become money conscious, and you will become a wealth creator. You will become a wealth creator. राजा को व्यापारी नहीं बनना चाहिए, लेकिन राजा को व्यापार समझना चाहिए. समझ रहे हो? राजा को व्यापारी नहीं बनना चाहिए, लेकिन राजा को व्यापार समझना चाहिए. सो यू शुड नो हाउ टू वर्क ऑन इकोनॉमिक मॉडल. लॉ, Aren't we all part of some legal system? और आज के जमाने में तो 3 है लॉ, लोकल, नेशनल एंड इंटरनेशनल लॉ, isn't it true? So you should understand. तो पढ़ो रूल्स के बारे में, लॉ के बारे में, फॉरेन पॉलिसीज जो यहाँ पे चल रहा है और उस देश में क्या चल रहा है, यू शुड नो, बिकॉज एवरी फील्ड इज बिकमिंग ग्लोबल नाउ, isn't it true? आप ये नहीं कह सकते हम भारत में हैं, हम अहमदाबाद में हैं, राजस्थान में नहीं. Today we are actually living in a globalized world, and thanks to technology and this, isn't it? So you should know what's the governments across the world thinking about, and we've seen that in pandemic, isn't it? So you should be very good in your foreign policies understanding. What works in one country may not work in another country, and vice versa, isn't it? So this is called best practices from the globe. और मेरा एक छोटा रिक्वेस्ट है, आप लोग इंटरनेशनल कॉन्फ्रेंस के लिए जाते हो बाहर, प्लीज टॉक अबाउट इंडियन प्रैक्टिसेस टू देम ऑल्सो. 2 चीज सीख के आओ, 2 चीज सिखा के आओ. और मैंने ये सीखा लंदन में. मेरे को वहां पे इंडियंस, हमारा गुजराती कम्युनिटी तो वेरी पॉपुलर है वहां पे, एंड आई वॉज क्वाइट सरप्राइज्ड एंड हैप्पी. उन्होंने मुझे कहानी बताई, एंड द कहानी गोज अबाउट चाय. चाय पे चर्चा, 1 पर्सन बिकम ए प्राइम मिनिस्टर ऑल्सो. चाय पिया आपने अभी? तो चाय इतना बड़ा पावरफुल चीज है, एंड देयर इज अ कनेक्शन ऑफ टी एंड इंडिया एंड ब्रिटेन. तो लंदन में कहानी सुन रहा हूं. कहानी ऐसे है कि इंडिया में चाय कौन लेके आए, हु बॉट द हैबिट ऑफ टी? इंग्लिश. दैट्स ट्रू. और आप देखोगे जितने भी चाय के बागान है, दे आर इन माउंटेन एरियाज, इजंट इट? दार्जिलिंग, इधर यहाँ पे ऊटी, जितना भी, बिकॉज ब्रिटिशर्स व्हेन दे केम टू इंडिया बहुत गर्मी हो रही थी, इजंट इट? तो हिल स्टेशन जाते थे और वहां पे चाय का बागान, टी, कॉफी एंड ऑल दोस थिंग्स. अब हुआ क्या कि बिफोर टी वॉज इंट्रोड्यूस टू इंडियंस बाय ब्रिटिश, यू नो व्हाट वाज आवर स्टेपल ड्रिंक? घर घर में, गांव गांव में क्या पीते थे? छाछ. यू आर एब्सोल्युटली राइट, है कि नहीं? इंडिया वॉज ए मिल्क कंज्यूमिंग कंट्री. मिल्क एंड मिल्क प्रोडक्ट्स, इजंट इट ट्रू? अलग अलग जगह जाओगे इंडिया में, आज भी छाछ पीते हैं. पीते कि नहीं पीते? अलग अलग, यहाँ पे तो कुछ और बोलते हैं, वहां पे कोई मट्टा बोलते हैं महाराष्ट्र में, और साउथ में तो तमिलनाडु में मोर बोलते हैं. अमूल अंडरस्टूड दैट, इट बिकेम द वर्ल्ड्स लार्जेस्ट प्रोड्यूसर ऑफ मिल्क. तो हुआ क्या कि इंडियन है ना, हम लोग नया ले लेते हैं बट पुराना छोड़ते नहीं है. तो चाय दिया, एंड बाय द वे टी इज ऑलवेज एक्चुअली यू नो विदाउट मिल्क, इजंट इट ट्रू? इंडिया बोला कि ये दे और मेरा दूध भी ले. So we accepted tea, but we did not leave milk. अभी तो चलो टी विथ मिल्क हो गया, इसलिए पूछते हैं ना, डू यू वांट विथ मिल्क? तो हम देखते हैं विथ मिल्क तो होना ही चाहिए. And the people who understand all these things will face no competition. देखो चाणक्य वाज अ वॉर स्ट्रेटजी. हम हमेशा बोलते दुश्मन को कैसे हराना. अरे दुश्मन को हराना छोटी बात है, दुश्मन को समझना बड़ी बात है. I'll repeat the statement. दुश्मन को हराना छोटी बात है, दुश्मन को समझना बड़ी बात है. And that's why before you fight the battle, you should know the psychology of the enemy. Isn't it true? कोई भी फील्ड हो. तो यहाँ पे दुश्मनी की बात नहीं कर रहे, चाणक्य की नीति के बारे में बात कर रहे. So my request to all of you is that please, whatever you practice, document it and give it back to them also, so that the world can be a better place. ठीक है. Anyway, so देखिए चाणक्य ने और किस किस विषय पे लिखे हैं? जेमोलॉजी, आयुर्वेदा, आर्किटेक्चर. बाय द वे सूरत में पूरा डायमंड कम्युनिटी है ना. You'll be surprised, India was the richest country in the world because of jewelry. हमारे यहाँ पे गोल्ड जो है ना, हमारे यहाँ पे इतने सारे आभूषण थे, we can't even believe it. और विजयनगर एम्पायर के बारे में आप स्टडी करोगे, एक्चुअली हीरे जवाहरात रास्ते पे बिकते थे. मैं सुनता था यही सब कैसे बड़ी बड़ी बातें करते हो, बट इट्स ट्रू. हमारे यहाँ पे अभी छोड़ो, विजयनगर की बात छोड़ो, आजकल कोई भी टीवी में गोल्ड का ऐड देखना आप. मलबार ज्वेलर्स, कल्याण ज्वेलर्स, जॉय आलुकास, सब एक स्टेट के. कहाँ के? केरला. केरला में कभी गए हो? कोचिन में एमजी रोड, गोल्ड के दुकान, छोटे छोटे दुकान, मिनिमम 2 फ्लोर्स. ये कोई पुरानी बात नहीं है. एंड देयर इज अ टेंपल इन केरला, पद्मनाभ स्वामी क्षेत्र, सुना है? तिरुपति के बहुत आगे हो. So what I'm telling you is that यहाँ पे there are models. चाणक्य अंडरस्टूड हमारा इकोनॉमिक मॉडल थोड़ा अलग है. आयुर्वेद के बारे में बात किया उसने, आर्किटेक्चर के बारे में बात किया, बहुत सारे सब्जेक्ट है, 180 टॉपिक्स इन वन बुक। कभी सुना है आपने? वन टॉपिक के ऊपर 100 बुक्स, बट 100 टॉपिक्स इन वन बुक। That is Chanakya Niti. That is the kind of an intellectual ability he had developed. But very important, psychology. It survives the test of time as the book has been based on the psychology of human being. He is a psychologist also. It may not be the way of modern psychology, but उनको पता था कि हम व्यक्ति के साथ काम नहीं करते, हम व्यक्ति के मन के साथ काम करते. Isn't it true? As doctors, all of you know, you don't work with the patient, you work with the mindset of the patient. True or no? मुझे याद है मेरे अच्छे एक स्टूडेंट है, इज अ डॉक्टर, मेनी ऑफ माय स्टूडेंट्स आर डॉक्टर्स, तो वैभव सर, तो उन्होंने मेरे को एक बार बहुत अच्छा प्रश्न पूछा था. यू नो, आई जज द पेशेंट थ्रू ओनली वन क्वेश्चन. बोले ये क्या सवाल है, मुझे भी बताओ, तुम्हारा डॉक्टर फील्ड का रहस्य. इफ ए पेशेंट कम्स टू मी ड्यूरिंग द प्रोसेस ऑफ डायग्नोसिस एंड गिविंग द ट्रीटमेंट, आई आस्क हिम और हर ओनली वन क्वेश्चन, हाउ डू यू सी योरसेल्फ आफ्टर 10 days? हाउ डू यू सी yourself after 10 days? So suppose that patient is having some physical problem, he or she is not able to move. If he says, you know, 10 दिन के बाद मैं fit, I am going to walk out from this hospital, I can work on that person. If somebody says, you know, क्या करे, अभी दिन के आखिरी, क्या जीवन के आखिरी दिन है, गिन रहा हूँ, you can't do anything. फिर थोड़ा बहुत कर देना. So it's very important to know the psychology and inspire the people. Anyway, all this is different. But what I am trying to tell is that this is all past knowledge. Now let us go to application of the knowledge in our field, which is leadership in the medical field. तो पहली बात, चाणक्य के गुरु कौन थे? बहुत सारे गुरु थे, उसमें 2 गुरु है, ये है शुक्र बृहस्पति. ओम नमः शुक्र बृहस्पतिभ्याम. अर्थशास्त्र का जो पहला मंगलाचरण है वो ये है. इसमें 2 गुरु के नाम है, दिख रहे हैं आपको नाम? शुक्राचार्य एंड बृहस्पति. शुक्राचार्य किसके गुरु थे? दानवों के, और बृहस्पति देवों के. सो हम हमेशा बोलते हैं सोचना कैसे है, दोनों तरीके से, वर्स्ट सिचुएशन एंड बेस्ट सिचुएशन. थिंक ऑफ द वर्स्ट एंड प्रिपेयर फॉर द बेस्ट. इवन इफ द पेशेंट इज कमिंग टू एट द लास्ट लेवल, you don't give up hope, isn't it? But you plan for the best and prepare for the worst. In the management field, this is called risk management. नहीं तो क्या, कोई बात नहीं. So whenever we are thinking like a leader, the leader will prepare for the worst. He'll be ready for the worst, but he'll also prepare for the, दोनों एंगल से सोचना है, ऐसा मतलब हो जाएगा, हो जाएगा. And that's why I say positive thinking will not help you to after a point, isn't it? Positive thinking is required. Be an optimist, or don't be a pessimist, be realistic. Isn't it true? So we always need to know how to work on ourselves and others. ठीक है. So what I'm going to do, I'm going to teach you one leadership model today in the given limited time. कि आप अगर एक छोटा क्लिनिक में हो या बड़े हॉस्पिटल में हो, how to run it like a leader. It's called सप्तांग. अंग का मतलब क्या है? Parts. एंड सप्त का मतलब क्या है? 7. पंचांग सुना है आपने? कैलेंडर, पंचांग होते हैं उसमें. अगर आप लीडर बनना चाहते हो तो कोई भी संस्था हो या छोटा हो, यू शुड ऑलवेज टेक केयर ऑफ 7 थिंग्स. एंड इफ यू आर एबल टू टेक केयर ऑफ 7 थिंग्स, यू आर ए लीडर. ओके, तो दिस इज अ वेरी इंटरेस्टिंग मॉडल कॉल्ड सप्तांग. इसके ऊपर बहुत सारे रिसर्च किए हैं हमने, और आपको भी थोड़ा शेयर करूंगा. इसके ऊपर किताब भी लिखी है. बट मोर देन दैट, इट्स इंपॉर्टेंट टू नो दैट यू शुड थिंक इन नंबर्स. हम भी वो देखते हैं ना, कोई भी चीज आंकड़ों में बात करो, isn't it? What is the body temperature? I'm sure there are various measurements. If you can think in numbers, you can be a good leader. And if you can think in numbers, you can take the right decisions. Isn't it true? People who can't measure things can never become leaders. So what is the सप्तांग? कहानी ऐसी आती है कि चाणक्य अपने स्टूडेंट को सिखा रहा था कि राज्य को कैसे संभालना, हाउ टू टेक केयर ऑफ योर प्रोफेशन. तो उसने पूछा राज्य होता क्या है? मेरे को राजा बना दिया, लेकिन पता नहीं राज्य होता क्या होता. राज्य के 7 अंग होते हैं. स्वामी, अमात्य, जनपद, दुर्ग, कोश, दंड, मित्राणि, प्रकृतयः. अर्थशास्त्र में आता है. तो एक राज्य के 7 अंग होते हैं. स्वामी मतलब राजा या रानी, यूनिजेंडर. ओके. अमात्य एक मंत्री होता है. प्रजा होती है, उसको कहते हैं हम जनपद. दुर्ग इंफ्रास्ट्रक्चर या फोर्टिफाइड सिटी. कोश, दंड, आर्मी एंड मित्र, ये सारी चीज अगर साथ में आ जाए तो अच्छा राज्य है। पहले मैं आपको थोड़ा पॉलिटिकली बताता हूं, फिर अपने प्रोफेशन पे आएंगे। अगर आप एक छोटा क्लिनिक भी चला रहे हो या बड़ा हॉस्पिटल, थिंक अबाउट दिस। आपके क्लिनिक में या आपके हॉस्पिटल में ये 7 अंग होंगे। तो मैं थोड़ा बिजनेस का एग्जांपल देता हूं कि अगर कोई बिजनेस चला रहे हैं तो स्वामी, देयर विल बी वन लीडर, इजंट इट? लेट्स से ही कैन बी डायरेक्टर, इजंट इट? या सीईओ, जो भी आप बोल दें। बट कैन ही वर्क अलोन? ही विल रिक्वायर अमात्यास, इजंट इट? हेड ऑफ डिपार्टमेंट्स, अलग अलग डिपार्टमेंट्स के हेड तो हो गया अमात्य। जनपद, यू रिक्वायर क्लाइंट्स, इजंट इट? राजा है, मंत्री है, लेकिन प्रजा किधर है? बट प्रजा भी है, लेकिन इंफ्रास्ट्रक्चर, द इक्विपमेंट्स, द प्लांट, द मशीनरी, एंड देन कोश, फाइनेंस भी लगता है, दंड, योर सपोर्ट सिस्टम, एंड देन फाइनली मित्र, द पीपल हु सप्लाई, वेंडर्स, सप्लायर्स एक्सेट्रा। तो आप देखोगे कि अगर आपके 7 अंग ठीक है तो यू आर ए गुड लीडर। इट स्टार्ट्स विद लीडर ओनली। थोड़ा हम इसको एक एकेडमिक एग्जांपल देखते हैं। स्कूल देखा है आपने? यू कैन अप्लाई दिस इन स्कूल ऑल्सो और ए कॉलेज। तो वहां पे स्वामी या स्वामिनी कौन? प्रिंसिपल। बट कैन द प्रिंसिपल रन द होल स्कूल? उसको लगता है अमात्य। अमात्य कौन है यहाँ पे? टीचर्स। जनपद, स्टूडेंट्स। दुर्गा, स्कूल इंफ्रास्ट्रक्चर, और आजकल पीपीटी के लिए वीडियो एंड ऑल दोस थिंग्स, इजंट इट? कोश, फीस, ग्रांट, स्पॉन्सरशिप, जो भी है। दंड, सपोर्ट सिस्टम इन अ स्कूल। नॉन एडमिनिस्ट्रेटिव, सॉरी नॉन टीचिंग स्टाफ, एडमिनिस्ट्रेशन, सिक्योरिटी, इजंट इट? मित्र, योर इकोसिस्टम। फॉर एग्जाम्पल, अगर आप देखोगे एक स्कूल के आजू बाजू में स्टेशनरी के दुकान होते हैं, बस के वेंडर्स होते हैं जो स्कूल में ड्रॉप करते हैं, वैन में लेके जाते हैं। तो इट्स वेरी इंपॉर्टेंट नो दैट इज ऑल्सो देयर। तो स्कूल में सारी चीज, इवन इफ वन इज मिसिंग, अच्छा प्रिंसिपल है, नो स्टूडेंट्स, अच्छे स्टूडेंट्स है लेकिन बस नहीं आता, सो एवरीथिंग पुट टुगेदर। कैन वी अप्लाई दिस इन आवर मेडिकल प्रोफेशन? सो लेट्स से यू आर द स्वामी, डोंट यू रिक्वायर एन असिस्टेंट? ये बहुत सारे बड़े बड़े हॉस्पिटल्स के प्रॉब्लम होते हैं। आई एम गुड बट नंबर 2 इज नॉट गुड, इजंट इट ट्रू? एंड उल्टा भी होता है, नंबर 2 इज गुड बट नंबर 1 समझता नहीं है। तो नंबर 1 नंबर 2, उसके बाद यू रिक्वायर पेशेंस, इजंट इट? दुर्गा, गुड इंफ्रास्ट्रक्चर, लेटेस्ट इक्विपमेंट्स। देन दंड, सॉरी दुर्गा, इंफ्रास्ट्रक्चर। कोश, imagine you are financially taken care, good na? That's why in the academic industry fees एक ही बार लेते हैं साल में, isn't it? Done, close, accounting close. कोश, दंड, you require support staff, you require मित्रस, यहाँ पे सब मित्र लोग मिल रहे हैं to discuss ideas. तो ये सारा जो है डिटेल में गए चाणक्य, will not go into that, but given the last 10 minutes, 15 minutes that I have, I'll try and cover one aspect of leadership over here. And leadership is equal to entrepreneurship. तो यहाँ पे मैं बोलूँगा स्वामी ए लीडर और स्वामिनी ऑल्सो एज ए लीडर। आप में क्या क्या गुण होने चाहिए? हम अभी बात कर रहे थे स्थित प्रज्ञा लक्षण, भगवत गीता में आता है। तो क्वालिटीज ऑफ ए स्थित प्रज्ञा, वैसे क्वालिटीज ऑफ ए लीडर चाणक्य ने जो बताया, डोंट बी अ बॉस, बी अ लीडर। ठीक है, फर्स्ट क्वालिटी ऑफ ए लीडर, वेरी इंटरेस्टिंग क्वालिटी, इसे कहते हैं विनय वृद्ध संयोग नित्यश्च विद्या वृद्ध एवं। इसका मतलब है ही शुड ऑलवेज हैव कांस्टेंट एसोसिएशन विद एल्डर्स इन लर्निंग फॉर द सेक ऑफ इंप्रूविंग हिज ट्रेनिंग। यहाँ पे आप ट्रेनिंग दे रहे हो ना, बड़े बड़े एक्सपर्ट्स आ रहे हैं, बट माई क्वेश्चन इज दैट आफ्टर दिस व्हाट यू विल डू? बहुत सारे लोग के साथ कार्ड लोगे, आप मिक्स करोगे, आप भी कार्ड एक्सचेंज करोगे, नंबर एक्सचेंज करोगे। योर रियल नेटवर्किंग स्टार्ट्स आफ्टर द प्रोग्राम इज ओवर। वरना क्या हो जाएगा, आपके सारे क्लिनिक और हॉस्पिटल इतने बड़े कार्ड के थप्पिया होंगे, है कि नहीं? या फिर यहाँ पे व्हाट्सएप में ग्रुप्स होंगे, कुछ नहीं होता। योर कॉन्टैक्ट्स शुड बी बियॉन्ड जस्ट नंबर्स। कैन यू गो एंड बिल्ड रिलेशनशिप्स? सो यहाँ पे जितने सारे एक्सपर्ट्स हैं उनके साथ रिलेशनशिप बनाओ। एंड लेट मी टेल यू वन थिंग, व्हेन यू आर अंडर प्रॉब्लम यू गिव देम अ कॉल, isn't it true? and they will tell you what to do. मुझे अभी भी याद है एक IAS ऑफिसर थे, तो उनकी एक नई पोस्टिंग हुई कि नए डिस्ट्रिक्ट में, तो उनके गुरु ने उनको बताया था कि देखो भाई जब भी समस्या आ जाए ना तो पीछे देखना। तो उसने समझा नहीं, लेकिन कोई तो समस्या था वहां पे, कुछ लॉ एंड ऑर्डर का प्रॉब्लम था, तो IAS ऑफिसर पता नहीं क्या करे, तो उन्होंने पीछे देखा। आपने कभी गवर्नमेंट ऑफिस में गए हो तो सरकारी ऑफिस में उधर एक लिस्ट होता है, पता है आपने, इनके पहले कौन लीडर थे, देखे आपने? तो एक 20 लोग का नाम था, तो उसने असिस्टेंट को बुलाया, बोलता है ये जो लिस्ट है ना उसमें से कितने लोग जिंदा है, उनका नंबर निकालो। तो बोला 20 में से 18 तो जिंदा है। सबको फोन किया उसने और 18 आइडिया मिले हाउ टू सॉल्व द प्रॉब्लम। गुड और बैड? हमारा प्रॉब्लम क्या हो रहा है? बिलीव मी, यू नो वी आर इन अ वेरी सोशल प्रॉब्लम नाउ विच वी डोंट सी। सब लोग बोलते हैं इंडिया इज यंग कंट्री, इंडिया इज यंग कंट्री, गुड, बट देयर इज अनदर साइड. People are aging also, isn't it true? And thanks to your fraternity, people are not going to die very fast. But are we using the experience of the retired people? We are going to easily live for 80, 90, 100 years, isn't it true? But the question is that after 60 what? After 70 what? So young doctors को suggestion ये है कि please take the advice and be in touch with the elders of your field. And believe me, you'll get breakthrough ideas. So the leadership quality is not about being perfect in your profession. A king is equal to the advice he gets from his advisors. King is equal to the advice he gets from the advisors. So be surrounded by good advisors. You know, आजकल स्टार्टअप का कल्चर बहुत चल रहा है इंडिया में, बराबर? सब यंग बॉयज एंड गर्ल डोंट वांट जॉब्स. यहाँ पे IIM अहमदाबाद है, एक बार यहाँ गया था. एवरीबडी वांट्स टू स्टार्ट सम कंपनी, करो यूनिकॉर्न यूनिकॉर्न यूनिकॉर्न, करो करो. But I'll tell you one thing, they'll get stuck somewhere, isn't it true? And that time, I always tell them, please go and take the advice of a person who is retired in your field. मैं आपको एक बात बताऊं, if you are a big company or a corporate, you require somebody called an independent director. पता है आपको? It's a government statutory requirement now. Independent director. लोग बोलते हैं independent director मिलते नहीं, अरे बहुत मिलते हैं. Then I tell them very interesting thing. एक आपको नुस्खा बताता हूं, मतलब क्या, आपके क्षेत्र के गवर्नमेंट के रिटायर्ड ऑफिसर्स को ढूंढो, उनको कोई नहीं पूछता, isn't it? Till they are in power, everybody likes them, they go to them, उसके बाद कोई नहीं पूछता. And I'll tell you, Dhirubhai Ambani actually used this model. When he wanted to start a petroleum company, he made a list of people who were the chairman of ONGC, HPCL, BPCL. Good or bad? अभी देखो, पूरा रिफाइनरी आपको पता है. If you are not good at something, there is somebody who was good at that before you. Vriddha Sanyoga. Make a list of experts before you go from here. And after you go from here, call them up. Believe me, that's your connection for life. It is not networking. It is Vriddha Sanyoga. Next quality of a leader. Attitude. Praja sukhe sukham rajnyaha prajanam cha hite hitam. Natma priyam hitam rajnyaha prajanam cha priyam hitam. कैसा होना चाहिए एटीट्यूड? जैसे आपने ऑलरेडी बोला, पेशेंट फर्स्ट, करेक्ट? सो प्रजा के सुख में राजा का सुख है, वैसे ही पेशेंट्स का रिकवरी में मेरा सुख है. इजंट इट ट्रू? कीप दैट एटीट्यूड, दैट इज व्हाट विल मेक यू सक्सेसफुल. लेकिन चाणक्य ये भी बोलता है, राजा को दो शब्दों का फर्क समझना चाहिए, सुख और हित. यू नो, एवरी ट्रीटमेंट मे नॉट बी सुखकारी, बट एवरी ट्रीटमेंट शुड बी हितकारी. इंजेक्शन सुखकारी है क्या? बट हितकारी है ना. तो समटाइम्स यू हैव टू पनिश ऑल्सो इन लीडरशिप. हमेशा मीठे मीठे बात करना लीडर नहीं है. नो, बहुत सारे लीडर्स हमने ऐसे देखे हैं, दे वांट टू बी गुडी गुडी. यू डोंट हैव टू बी गुड, यू हैव टू बी ग्रेट. एंड ग्रेट पीपल समटाइम्स यूज द रॉड ऑल्सो. इन लीडरशिप आपको दंड नीति समझनी चाहिए. जैसे यू नो, अपने घर पे भी जरूरत पड़ा तो हम देते हैं ना. बच्चा बोलता है मुझे स्कूल नहीं जाना है. अरे क्या नहीं जाना है? खाना नहीं खाना है, पढ़ाई नहीं करनी है. सो याद रखिए, सुखकारी होगा तो अच्छा है, नहीं तो हितकारी इज वेरी इंपॉर्टेंट. सो वी शुड बी लुकिंग एट द हित ऑफ द इंस्टीट्यूशन, द कंट्री, द पीपल, एक्सेट्रा. थर्ड क्वालिटी, ऑलवेज बी एनर्जेटिक. ये बहुत जरूरी है, उत्साहवर्धक. इफ ए किंग, ए लीडर इज एनर्जेटिक, हिज सब्जेक्ट्स विल बी इक्वली एनर्जेटिक. If he is slack and lazy in performing his duties, the subjects will also be lazy. पता नहीं अभी कोरोना आने वाला है, अरे कोरोना आने वाला है, तू कहां जाने वाला है? मैं घर पे बैठूंगा। यू सीन, आई थिंक मोस्ट ऑफ यू नो दिस, जो बुरी स्थिति में भी काम करते हैं वो लीडर बनते हैं, इजंट इट ट्रू? और उनका एक्चुअली ग्राफ ऊपर गया है, इजंट इट ट्रू? हम बैठे नहीं अभी। तो दो शब्द याद रखेगा, परिस्थिति और मनस्थिति। परिस्थिति कुछ भी हो, मनस्थिति शुड बी एक्टिव। हम जाते हैं, हम करते हैं। इफ यू सिट ओवर देयर, मैं आपको एक कॉर्पोरेट उदाहरण देता हूं। दो कंपनीज थे, पैंडेमिक की बात है, अभी तो चलो 1 साल हो गया उसके ऊपर। दोनों एक ही क्षेत्र के थे, एक ही फील्ड में, और एक था बिग बाजार। हैव यू सीन द सुपरमार्केट बिग बाजार? और दूसरा था डी मार्ट, यहां पे भी है ना। तो क्या हुआ आपको पता है? ड्यूरिंग दैट पैंडेमिक बिग बाजार ने बोला अभी क्या करे, कोई आता नहीं घर से बाहर। धीरे धीरे वो तो अभी बिक गई, राइट? वो तो चला। बट यू नो व्हाट डी मार्ट डिड? उन्होंने अच्छा देखते हैं क्या प्रॉब्लम है, लोग नहीं आते, हम लोगों के पास जाते हैं और गवर्नमेंट को पॉलिसी चेंज करते हैं। इट्स एन एसेंशियल सर्विस। डी मार्ट के सेल्स ऊपर गए, इजंट इट ट्रू? एंड दे वर एक्चुअली वर्किंग 24/7। और मुझे याद है हम एक बार डी मार्ट में शॉपिंग को गए थे ड्यूरिंग पैंडेमिक। तो मैंने उधर के काउंटर की एक लड़की को पूछा, इतना काम करते, बोलते बोनस भी मिलता है, इतना सेल्स हो रहा है। और हमारे यहाँ पे हमको घर पे भी रात को छोड़ के आते हैं। सो परिस्थिति हुई, इंडस्ट्री हुई, लेकिन एक बोलता है कुछ नहीं कर सकते, दूसरा बोलता है नहीं, रास्ता निकालो और धंधा बढ़ाओ। और एक उदाहरण देता हूं, पैंडेमिक में सारे इंडस्ट्री इफेक्ट हुए, सारे होटल बोलो, रेलवे बोलो, प्लेन बोलो, जो भी है। उसमें से एक इंडस्ट्री है विच इज पार्ट ऑफ रिटेल। और मुझे बॉम्बे के उनके चेयरमैन ने ये कहानी बताई है। यू नो ऑप्टिशियंस, उनका धंधा बंद हुआ। पहला देयर वर 3 फेजेस ऑफ लॉकडाउन। फर्स्ट में सबका बंद हुआ, फिर ऐसा थोड़ी चलेगा। इन्होंने नेक्स्ट में गवर्नमेंट ने बोला लॉकडाउन, सब दुकान बंद। तो इन्होंने क्या किया, उनका एसोसिएशन, जैसे आप लोग का एसोसिएशन है, दे वेंट टू द गवर्नमेंट एंड सेड कि यूजिंग स्पेक्स और ग्लासेस इज अ एसेंशियल सर्विस। ट्रू और नो? उन्होंने प्रेजेंट किया तो बोला इट इज नॉट एसेंशियल सर्विस, इट इज। आपको कंप्यूटर चलाना है, बैंकिंग चलाना है, वो एसेंशियल सर्विस है। हमारा चश्मा नहीं है क्या? एंड दे मेड अ रूल, इजंट इट ट्रू? एंड टुडे इट इज वन ऑफ द बिगेस्ट इंडस्ट्रीज। लेंस कार्ड सुना है आपने? वी गॉट फॉरेन फंडिंग कमिंग नाउ। So one, it is not about chasma, it is about how you make a strategy in the bad situation and take it to an advantage. So याद रखिए, it is not परिस्थिति. How many of you are ready for pandemic if it happens again? बाकी लोग सोचो और इनसे इंस्पिरेशन लो। और मैं बोलता जब भी प्रॉब्लम हो, फोन है फ्रेंड, तू क्या कर रहा है? चलो मैं भी करता हूँ। And you have done wonderful work in this particular field. Yeah, we'll just take up questions. I just got 2 more slides to go. देखो ये बहुत इंपॉर्टेंट है, हम बुद्धि योग की बात कर रहे हैं। ए लीडर शुड गैदर इंफॉर्मेशन एंड प्रोसेस इट। यहां पे आपने बहुत लर्निंग सीखा होगा ना, बट डू यू थिंक ओवर इट? किसी नोट्स बना रहे हैं, सो यू हैव टू थिंक ओवर इट एंड यू विल गेट न्यू सॉल्यूशंस। द अफेयर्स ऑफ ए किंग, अ लीडर इज ऑफ 3 टाइप्स, प्रत्यक्ष, परोक्ष, अनुमेय। प्रत्यक्ष मतलब देखा, आपने बहुत सारे स्पीकर्स को देखा, सुना, प्रत्यक्ष। परोक्ष नहीं देखा लेकिन समझा, ही और शी पुट अ केस स्टडी, उसके ऊपर सोचो। एंड अनुमेय, अनुमेय मतलब देखा भी नहीं, सुना भी नहीं, लेकिन समझा। देखा नहीं, सुना नहीं, फिर भी समझा। दैट इज योर टेक अवे फ्रॉम दिस पर्टिकुलर कॉन्फ्रेंस। लाइक फॉर एग्जाम्पल कहते हैं आग देख के पता चलता है कि धुआं है, सॉरी धुआं देख के पता चलता है कि आग है, आग को देखा नहीं। सो सपोज यू आर फ्रॉम अहमदाबाद बट देयर इज समबडी फ्रॉम जयपुर, उसने कहा हमारे इधर ये ट्रेंड चल रहा है, आपने देखा क्या? पर आपको पता चला कि दिस ट्रेंड कैन कम टू अहमदाबाद आल्सो, इजंट इट? सो योर अपॉर्चुनिटी इज एक्चुअली लर्निंग फ्रॉम अदर्स, बट यू हैव टू प्रोसेस इट। इसलिए वो जो आजकल चल रहा है डाटा एनालिटिक्स, डेटा एनालिटिक्स, डेटा इज नॉट अ प्रॉब्लम बट डू यू एनालाइज इट? तो इंफॉर्मेशन को प्रोसेस करना इज द लीडरशिप क्वालिटी। सो दिन में आधा घंटा आप एक काम करो, आज से लेके think about information received, process it, and you will get insight and foresight. Otherwise, whatever you will get outdated. Okay? I hope all of you have systems and processes. Software आजकल बहुत है, apps बहुत है. You have to take continuous reports from people. A leader should constantly hold an inspection of their men, of their works. लोगों ने क्या काम किया, इन्वेंट्री, ये सब उसका रिपोर्टिंग स्ट्रक्चर बनाओ, वरना क्या लोग भी भूल जाएंगे, आप भी भूल जाओगे। आई होप ऑल ऑफ यू हैव स्मॉल और बिग प्रोसेसेस. वही बोलते छोटा क्लिनिक हो या बड़ा हॉस्पिटल हो, थिंक लाइक ए लीडर एंड एंटरप्रेन्योर. जिसका सिस्टम प्रोसेसेस नहीं है वो लीडर नहीं है. A leader always gives importance to system and process and documentation. I'll come to last 2 slides. This is about finance, my favorite topic. All undertakings are dependent first on the treasury. True or no? कुछ भी नया करोगे तो बजट लगता है. And leaders always do excellent budgeting. Okay? Therefore, the leader should look into the treasury first. Again, it is not being money minded. It is being money conscious. हर चीज के लिए पैसा लगता है कि नहीं लगता है? लगता है. And therefore doing a budgeting exercise is very important. In fact, even if you are not from finance field, I would suggest all of you should have some friend who is good in the finance field, not just chartered accountant. Okay, another one. Be ever active. Be ever active in the management of the economy because the root of wealth is economic activity. वो बोलते चरती, चलते रहो चलते रहो चलते रहो, कुछ ना कुछ करते रहो. पता नहीं कुछ नहीं होने वाला. अरे कुछ नहीं होना, तू तो है ना, कुछ तो कर. इफ यू नॉट एक्टिव, देखो आगे क्या बोलते हैं, इनएक्टिविटी. अगर आप बैठ जाओ तो क्या होगा? इनएक्टिविटी ब्रिंग्स मेटीरियल डिस्ट्रेस. जो है वो भी चला जाएगा. विदाउट एक्टिव पॉलिसी बोथ करंट प्रॉस्पेरिटी एंड फ्यूचर गेन्स आर डिस्ट्रॉयड. जो है वो भी जाएगा और आने वाला तो कभी नहीं आएगा. तो कार्य करते रहो. So 2 words for entrepreneurs. कर्म योग एंड उद्योग, दोनों में योग है. कर्म योग करते रहो. हमने ऑलरेडी भगवत गीता में सिखाई है, फल की इच्छा मत करो, करो, बट फल की इच्छा चाहिए तो उद्योग करो. उद्योग मीन्स इंडस्ट्री, राइट? उद का मतलब उठना, बैठे रहो, पता नहीं क्या होगा, मेरे को उठा के लेके जाओ. ए लीडर शुड इंस्पायर अदर्स टू गेट अप. कल करे सो आज कर, आज करे सो. अब हमारे यहाँ पे उल्टा है, आज करे सो कल कर, कल करे सो बरसो. कुछ भी नहीं हो तो अगले जन्म भी है ना अपने इधर. इतनी भी क्या जल्दी है जब जीना है बरसो? नहीं. राइट हियर राइट नाउ यू शुड बी एक्टिव. एंड फाइनली आई वुड सम अप बाय सेइंग प्लीज बी अपडेटेड. कंटिन्यूअस स्टडी. आप लोग सब इतना मेरे बाद भी लेक्चर सुना, बाप रे. ठीक है, पढ़ते रहो पढ़ते रहो पढ़ते रहो, लेकिन दिमाग भी यूज करो. कंटिन्यूस स्टडी से क्या होता है, उसका फल क्या है? आफ्टर स्टडिंग एंड लिसनिंग एंड लर्निंग यू गेट अ बेटर इंटेलेक्ट. इजंट इट ट्रू? बट लेट मी टेल यू, वी आर अ जनरेशन ऑफ इंफॉर्मेशन पोल्यूशन. ओवर होता है कि नहीं होता है? और हमारे यहाँ पे मिस्टर व्हाट्सएप भी है. इतना डेटा आ रहा है, बाप रे. ठीक है, कोई बात नहीं, बट प्रोसेस इट एंड देन उसका सार निकालो. आई होप यू डू अ एक्सरसाइज बिफोर यू गो टू स्लीप एवरी डे. इट्स कॉल्ड डेली एनालिसिस. एंड अभी न्यू ईयर की शुरुआत हुई, अगर आप नहीं करते, मेरा एक सजेशन है, एवरी डे बिफोर यू गो टू बेड 5 या 10 मिनट निकाल के एक डायरी लिखो. डायरी लिखना तो सबका बंद हो गया ना. इट्स ए गुड वे ऑफ एनालाइजिंग, आज मैंने क्या सीखा, क्या करना बाकी है. इजंट इट ट्रू? सो कंटिन्यूअस स्टडी बिकम्स योर ट्रेन इंडिया. आपकी बुद्धि शार्प हो जाती है. बट फ्रॉम इंटेलेक्ट शुड कम प्रैक्टिकल एप्लीकेशन. कुछ तो करो. ज्ञानी से कुछ नहीं होता. ज्ञानी को कुछ ना कुछ एक्शन में डालना है. And from practical application, results, self position, you become an expert. सीखो, अप्लाई करो और एक्सपर्ट बनो. और एक्सपर्ट बनने को दुनिया को दो. So keep learning, attend courses, जो भी आप अपने फील्ड में करते हैं. Update your knowledge in your field. Study every day for an hour. एक स्टोरी बोल के खत्म करूंगा. ये जो सप्तांग है मैंने आपको बता दिया. The story goes like this, and it's a real story. एक बंदा था 72 years old. 72 years old. वो हार्वर्ड में गया फॉर लर्निंग आर्टिफिशियल इंटेलिजेंस. रिटायर्ड पर्सन. तो प्रोफेसर ने पूछा, आप तो इतने बुजुर्ग है, 72 years old, आर्टिफिशियल इंटेलिजेंस क्यों सीखने आ रहे हैं? तो उन्होंने सिंपल सा बात, आई एम द चेयरमैन ऑफ ए कंपनी. ओके, और मेरे जो यंग बंदे हैं ना, दे नो बेटर देन मी. और आजकल मैंने उनके बातें करने का कुछ तो सुना, आर्टिफिशियल इंटेलिजेंस 10 साल पहले. तो मैंने अपने एक जूनियर को बुलाया और बोला, ये आर्टिफिशियल इंटेलिजेंस क्या होता है? बोलते हैं आर्टिफिशियल इंटेलिजेंस तो आपने सुना, देयर इज वन मोर थिंग. बोले वो क्या है? मशीन लर्निंग. हैव यू हर्ड अबाउट दीस 2 टर्म्स? तो मैंने थोड़ा इंटरनेट पे आर्टिकल देखा, देन आई रियलाइज कि इतना बड़ा फील्ड है एआई. और मेरा पूरा दुनिया, मेरे जो इंडस्ट्री में सब लोग जो है, द यंग बॉयज आर टेकिंग ओवर द होल सिस्टम थ्रू एआई एंड एमएल. तो मैंने किसी को पूछा कि मेरे एज ग्रुप वाले के 70 वाले को, अरे ये एआई क्या होता है? तो मुझे नहीं पता. तू क्या कर रहा है, रिटायर हो गया हूं। तू क्या कर रहा है, अभी भी काम कर रहा हूं। फिर किसी और को पूछा तो बोला एक काम करो, बहुत सारे बुक्स पढ़ने लग गए, इतना इंटरेस्ट हो गया, ही वेंट टू हार्वर्ड, डिड अ कोर्स एट द एज ऑफ, व्हाई एम आई टेलिंग यू इज दैट, ऐसा मत सोचो कि ज्ञान अभी मैं तो मेरा टाइम खत्म हो गया, नहीं नहीं नहीं, सीखते रहो। एंड आई टेल यू, चाणक्य बिलीव्ड इन रिवर्स मेंटरिंग, यंग बच्चों से सीखो, दे मे टीच यू समथिंग विच यू डोंट नो। सो नए टेक्नोलॉजी आने वाले अपने फील्ड में आ चुके हैं, बट आर वी अपडेटेड, कैन यू यूज टेक्नोलॉजी? It only requires some commitment and discipline. Believe me, everybody can be a master of your field. So इतना बोल के मैं समाप्त करूंगा. If you have 5 minutes question and answer, I'll be happy. But जिसे ढूंढा गली गली, all management leadership is there in our own culture. Read that also and apply it globally. Thank you so much. Somebody had a question there, yeah. Anybody? Yeah. 1 second, sir. Let's get the mic. This is your takeaway. इसका picture निकाल सकते हो आप. No copyright issues, huh? PPT is also yours. Copyright is only right to copy in India. Sir. Yeah.
Good evening, sir. Thank you very much for the excellent your extempore and your seminar and your way of giving this lecture. But the last word you used, artificial intelligence and machine learning, I could not get it. If you can, another few minutes.
Sure. How many of you are aware of AI? So I think बहुत सारा discussion हो सकता है. But I'll tell you what is artificial intelligence. See, you know, in our working, there are many things that get automated or repetitive, isn't it true? Like for example, सुबह उठ के जाना है, सुबह उठ के जाना है, सुबह उठ के जाना है. वैसे कंपनियों में भी होता है. Every day you have to do. For example, you require manpower to do that processing. But today what is happening? Computer can do that. Like I'll give you a simple example. पहले हम किधर भी जाते थे तो एक रजिस्टर होता था, हम नाम लिखते थे, बराबर, अटेंडेंस. याद है आपको? जैसे यार यही रिपीटेटिव जॉब है तो व्हाई डोंट यू यूज एआई? तो वहां पे एक सॉफ्टवेयर डाल दिया, तो आपको सिर्फ पंच करना पड़ता है, राइट? व्हाट इज मशीन लर्निंग? तो इतना डाटा हो गया है, द मशीन लर्न्स एंड टेल्स यू ये बंदा हर दिन 15 मिनट लेट आता है, तो मशीन विल लर्न एंड टेल यू द आउटपुट. तो आपके क्षेत्र में यू विल सी पैटर्न्स, इजंट इट ट्रू? Like for example, psychology के फील्ड में there is a big discussion happening on midlife crisis. Midlife crisis पता है? 40-50 साल करे क्या? और अभी बहुत सारा रिसर्च चल रहा है, वेरी इंटरेस्टिंग पॉइंट कॉल्ड एजिंग, isn't it true? दुनिया भर में सेमिनार्स चल रहे हैं, बिलियंस ऑफ डॉलर्स. इमेजिन आप यहाँ पे बैठ के एआई को यूज करके अफ्रीका में, अमेरिका में एजिंग में क्या हो रहा है यहाँ पे सीख सकते हो कि नहीं? So coming back, how the artificial intelligence field works, it's called data points with lot of data and insights. So it's a very different field. I'm not a technology person to answer this question, but to tell you that every field will get automated, isn't it true? अब मैं उल्टा बोलता हूँ. Let's say, let me ask you a question. Let's say a patient comes to you, okay, for the first time, or the second time, or the 10th time. How much time do you average spend on a patient? Average?
3 minutes.
15 minutes? 10 minutes? 2 मिनट वाले भी है, बराबर है? So let's say, you know, एक रेंज लेते 10 मिनट, कोई 2 मिनट वाले, कोई 15 मिनट वाले, ओके? और लेट्स टेक के एवरेज 10. तो आप 10 मिनट अगर एक पेशेंट को देखते हो, दिन में कितना, 1 घंटे में कितना देख सकते हो? कितना? 1 घंटे में 10 मिनट है तो 6. सिंपल कैलकुलेशन. बट लेट मी पुट द अदर वे अराउंड. अगर आप 3 घंटा अपने डिस्पेंसरी में बैठते हो तो कितना पेशेंट हो गया? 18. चलो और थोड़ा उसको राउंड ऑफ करके 20 पेशेंट, but you can use artificial intelligence and actually meet 100 patients. Good or bad? Not good. Bilkul sahi hai. But if you come to know what is the problem of that particular person, so what artificial intelligence does is that they will study the person before he comes into your given. इसमें दो चीज होता है, अनुभव से आप वो बोलते हैं ना, I've seen doctors और patient को चलते हुए देख के उनको पता चलता क्या प्रॉब्लम है. That is called अनुभव. True or no? चलते उनको पता चलता है इसको ये प्रॉब्लम है. Isn't it true? But the process has to be followed. बैठो, बात करो, ये करो, समझो. या फिर एक प्रोसेस होता है नस देखने का, isn't it? दादी माँ का नुस्खा वाला. But today that is getting replaced by your technology. Saying that इसलिए आप कोई डॉक्टर्स क्या करते हैं, नंबर 2 को पहले बोलते हैं उनको मिलके बाद में मेरे पास आओ. Isn't it true? So I'll do the final part of it. So coming back, technology is being used over there. I'll give you a simple example. How artificial intelligence and data and machine learning are being used. आप यहाँ पे गए एयरपोर्ट में सब जाते हैं, पहले तो आधार कार्ड दिखा दो सब हो गया. Isn't it true? Isn't artificial intelligence using and saving your time when you go to airport? बहुत सारे कंट्रीज में ऐसे एयरपोर्ट्स हैं कि आप पासपोर्ट के अंदर जा सकते हो. Isn't it true? You don't require another ticket also. So coming back, this is a big field. So in your field, you can maybe call an expert and maybe do something. So coming back, artificial intelligence is a field that you cannot avoid. But I will like to take Sir's point. Don't use artificial intelligence to such an extent that you forget to use natural intelligence. इतना भी robotic मत हो जाओ, human being. In fact, many of my American doctor friends tell, why American doctors are successful globally, Indian doctors in America? Because they connect to the heart first. तो उसके लिए सुनना पड़ता है, 15 मिनट नहीं, शायद आधा घंटा भी हो सकता है. Isn't it true? So human nature and technology can create the change. इसलिए यहाँ पे एक बहुत अच्छा किसी ने बताया, will technology replace human beings? The answer is no. But technology can help you reach your service to more human beings. Can I repeat it? Technology cannot replace human beings. Isn't it true? But technology can help you reach and serve more human beings. So that's one small example, sir. Maybe last question, if any. Yeah, please. Yeah.
Everybody in the world thought that Ukraine will fall down within.
Yeah.
Ukraine will fall down within 2 days, and that was Volodymyr Zelensky. Your views about him?
Pardon?
Your views about Volodymyr Zelensky?
मेरा तो एक ही व्यू है, leader.
No, just a little elaborate, please.
Yeah, sure. So this is a very interesting, different field. क्योंकि war है, यूक्रेन है. मैं तो जो मीडिया में और व्हाट्सएप में देखता हूँ उसका ही बोल सकता हूँ. But I can tell you one thing. Wars will keep happening across the globe. Isn't it true? दुनिया भर में कुछ ना कुछ युद्ध चलते रहेंगे. Remember one thing. War is never between two countries. It is always between two leaders. True or no? फिर से बोलता हूँ. My view. Wars are never between two countries. They are between two leaders. Wars is always between two leaders. कोई भी country हो, कहाँ पे भी हो, कल इंडिया भी रहेगा तो it's always the leader, isn't it true? So coming back to Ukraine, believe me, you cannot write off Ukraine because it's small. At the same time, you cannot write off Russia also. दो leader लोग बैठ के कुछ कर रहे हैं ना. My question, my analysis is different. What is India's role?
Great.
And I'll tell you, India has got a major role, isn't it true?
Right.
We have a very interesting role.
India is in a sweet spot.
Very sweet spot. And since you asked this question, I like to stop with a very interesting answer about war. World War I, World War II सुना है आपने? अच्छा, tell me one country. अच्छा, by the way, World War I और World War II कहाँ हुए थे? यूरोप में. India was not part of it, isn't it true? Right. हमको जबरदस्ती भेजा गया था because Britishers were ruling us. True or no? Right. Now there's a question to all of you. There was one country from Europe which did not participate in World War I and World War II.
Switzerland.
Switzerland. और क्या हुआ उससे फायदा?
We know it. Everybody.
Everybody put money into Switzerland.
सबके पैसे उधर है. सबके पैसे उधर है.
बल्कि तो हम दोनों झगड़ा कर रहे हैं, पैसा इधर आ रहा है. We are India is that country today. True or no? दुनिया भर का पैसा आ रहा है.
Very right.
So what is Switzerland?
अभी सबके पैसे हमारे यहाँ आ जाएंगे.
आ गए हैं सर. Please start making business plans. Or by the way, all the youngsters start becoming entrepreneurs. There's a lot of money in India, isn't it true? तो दुनिया भर झगड़ा करने दो और हमको झगड़ा स्टॉप भी करना है. But we are at the sweet spot financially also, isn't it true? So is our generation ready for the opportunity? And let me tell you, I come from Bombay, financial capital, and you are in Ahmedabad. Please go and talk to the bankers and what we call VCs. VC सुना है ना सबने? Not vice chancellor. बस believe me, we are at a very sweet spot. और सब लोगों ने देखा होगा वीडियो में, अगले 10 साल में हम लोग जो करेंगे वो बाद में 25 साल नहीं कर पाओगे. So we are at a very sweet spot. So yes, Russia, Ukraine, it could be tomorrow, China and Taiwan also. True or no? सब दिख रहे हैं. But what is your stand? And the stand the leader takes is very important. No? And finally, the praja can get affected positively or negatively. So let's use it for our benefit. Thank you so much.